Okay, so there's a let's say 10-year-old guy student, 10-year-old boy is brought to the clinic by the mother and has trouble in the school as well as at home. Um, cannot concentrate, is hyperactive. Diagnosis is
ADHD.
how many months should it be around ADHD to diagnose? How much? How long should the symptoms be? So 6 months, at least 6 months around. And what if he had difficulty sitting at desk in school, but was fine at home? Let's say he had the trouble with the focus and concentration and hyperactivity only in one setting. Let's say maybe only school, and is totally fine at home. Then that would not be ADHD, right? For ADHD, it has to be in two settings: school and home, home and church. Home. Basically two different settings for 6 months at least to diagnose ADHD. Um, these students have normal IQ, but they may have poor grades, so their IQ will be normal. Okay, and so what's the first line? First line of the drug for so the stimulants are usually the first line, methylphenidate, etc. But some parents might refuse the stimulants, right? And for them, um, you may use the non-stimulants. For example, atomoxetine, clonidine, guanfacine. Um, yeah. So intelligence is normal, but they may have difficulties in school. That it has to be there in two or more than two settings. There is another variant of this disorder, which is attention deficit disorder only, in which there are no hyperactivity symptoms or signs. All right. Again, I don't think that's important from your semester one context, but yeah, it's there as well. Um, autism spectrum disorder. Um, usually, so repetitive movements and ritualized behaviors. Some people they end up confusing it with Rett syndrome. Sometimes the hand wringing, in the Rett syndrome. Um, so this in Rett syndrome you will get neurological uh, regression and a lot of others. Over here it's only about the social and communication deficits, restricted interest. For example, the patient might only be interested, let's say, in stars. Maybe he knows a lot about stars, their names and all what happens over there, but doesn't is not interested in anything else. So he might have interest in certain, or increased head or brain size, more common in males. Conduct disorder and antisocial personality disorder. Again, they have the same symptoms and they have the same characteristic, except conduct disorder is before age 18, and after 18 you have antisocial personality disorder. Um, people end up mixing conduct disorder and oppositional defiant disorder on exam. So positional defiant disorder will not have you know illegal activities being done by the patient. In conduct disorder, in antisocial personality disorder, uh, the patient the person is doing activities that are unlawful, aggression towards people, animal, destruction, setting fires, theft. uh, on the other hand, and getting into fights and physical fights with people and stuff. On the other hand, in oppositional defiant disorder, there will be a pattern of defiance, argumentative with authorities, not talking back to the authorities in a rude manner, all that, but you won't have serious violations of societal norms or law. They won't be doing anything, that's sort of illegal. The patients with conduct disorder, they often end up in jails, for example, in juvenile detention centers because of their activities. On the other hand, a position defined patient won't end up in juvenile detention center. And for intellect, so if there's a let's say there's a 22-year-old person who gets into fights and criminal activities, but has no track record of doing those things before, let's say, age 18, what would be the diagnosis then? So that's not a psychiatric disorder, right? For unlawful and criminal activity to be a psychiatric disorder, and diagnosing it as antisocial personality disorder, so it has to be there from the early childhood, that is before age 15, all those. And if this is a 25-year-old guy, so he's simply a criminal, right? He goes on killing people or anything like that, he's simply a criminal instead of someone who has a specific personality disorder. Disruptive mood dysregulation disorder. The tantrums.
Bilal, question.
Mm-hmm.
In conduct disorders written after 18 often reclassified as antisocial personality disorder. So
Correct.
that is you're saying that that guy's just a criminal?
No, I'm saying that if if there are no symptoms of conduct disorder in a patient, when he was a child or when he was a teenager, and if someone has criminal behavior, starting at age 20, 25, you won't classify that patient having any personality disorder. He's just a, he's a simple criminal. All right, someone who will end up in jail, and that wouldn't be a psychiatric disorder.
Okay. And how do you differentiate that with antisocial personality disorder?
Differentiate with what within antisocial personality disorder?
So you were saying that for conduct disorder, the person has to have symptoms before 18, right?
So in conduct disorder, you have those unlawful activities and everything going on before 18, all right? And antisocial personality disorder patient has all of these things going on after 18, but there is a history of conduct disorder. So antisocial personality disorder cannot be diagnosed without the patient having conduct disorder early. Antisocial personality disorder is just a continuation of conduct disorder. The patient cannot have diagnosis of antisocial personality disorder at age 20 when he had no history of conduct disorder, right? Conduct disorder has to be there in the adolescence for a patient to be diagnosed as antisocial.
Okay, got it. Thank you.
Yeah. So if person has all those unlawful activities, but has no history of conduct disorder, that would not be antisocial personality disorder.
Okay, and if let's say the person has conduct disorder in childhood, and then at 18 he stops having any disorder, then...
So you won't diagnose him as antisocial
Bilal,
personality disorder.
there is a lot of distortion. Can you mute?
Yeah, sure. Let me see. Okay, I think we're good now. Yeah. So if the patient has conduct disorder, receives management, psychotherapy and stuff, and is fine, then it's fine. He doesn't have antisocial personality disorder. That would not negate his conduct disorder. All right, but you cannot have antisocial disorder without having a prior history of conduct disorder. And the personality disorder, the problem with personality disorders, they are very difficult to treat. Medications don't work on these patients. Psychotherapy is the way to go about them. But again, these patients, they don't think they have any problem. They don't find any problem with themselves, and they think that there's people surrounding environment, people, that's what is wrong, and so it's difficult to treat these patients. All right. So yeah, psychotherapy, CBT, etc. for these patients to make them understand their own personality. But these they don't acknowledge that they have a problem. They think the problem is with the people and everything else. Disruptive mood dysregulation disorder. So children throw tantrums, right? But if the child is constantly angry and irritable between outbursts, that is when you say it is disruptive mood dysregulation disorder. Okay, if there is a child who, of course, toddlers, they throw temper tantrums, outbursts, and all of that in early. But these patients with disruptive mood dysregulation disorder, they will be constantly angry and irritable between the outbursts. So there won't be any periods, normal periods. And again, CBT, stimulants, antipsychotics, and intellectual disability should be differentiated from specific learning disorder by the fact that there is global cognitive deficit, with the memory, reasoning, language, writing, everything. So it's a global and these patients require proper occupational therapy, special education, all of that. Yeah, so talking about the drugs we just talked about. So stimulants will increase catecholamines in the synaptic cleft, and that's also the mode of action of methamphetamine, also called. So if this is MDMA, that would be ecstasy, for example. Lisdexamfetamine is used for which disorder? Binge eating disorder, for example. So ADHD, narcolepsy, binge eating disorder, and the primary side adverse effect that they're going to test on the exam would be hypertension and tachycardia, and weight loss. Weight loss, hypertension, these are the two important side effects that usually will be tested on the exam day. So these alpha 2 agonists, which means they're inhibitory. Alpha 2 is inhibitory GI. So previously clonidine used to be used for hypertension, but it has been discontinued for a long time because with this clonidine has to be taken regularly. Patient misses a dose, can develop rebound hypertension, severe rebound hypertension. So usually it's not used for hypertension as such. All right. Yeah, this is in point table again. So stimulants for ADHD, the first line text sort of, it's called withdrawal benzodiazepines. Also for cocaine intoxication, you use benzodiazepines as you treat the patients with benzodiazepines. Do not make it alpha antagonist or beta blockers or stuff like that. Beta blockers, you never give them to patients on cocaine because they can cause uninhibited action on alpha receptors. So yeah, benzodiazepines. And bipolar, lithium, unless patient has chronic kidney disease. If they mention in the question that the patient has chronic kidney disease, don't fall for lithium, instead go for more likely valproate. But if the patient has hepatic disease, and valproate is known for hepatotoxicity, so you won't go for valproate. Lamotrigine is known for its side effect, which is, from exam context,
Stevens-Johnson syndrome.
Yes, correct. And carbamazepine is known for two SSRIs and sorry, carbamazepine is SIADH, and what other?
Agranulocytosis.
Yes, correct, agranulocytosis. Bulimia nervosa, SSRIs, don't give SSRIs to anorexia nervosa. And the only way you're going to differentiate between the anorexia nervosa and bulimia nervosa on exam is via BMI. That's the only thing. All right. Anorexia nervosa patients might have, purging behavior, purging type of anorexia nervosa. When patient eat and then throw up, all right, induce vomiting and all of that. So the only differentiation between bulimia nervosa and anorexia nervosa is the BMI. Okay, 18.5 below, less than 18.5, go for anorexia nervosa, and then management changes. Bulimia nervosa, SSRIs, all right. And on the other hand, anorexia nervosa, these patients usually require dietary rehabilitation, and sometimes they have to be admitted. Okay, and they have to be admitted and given nutrition through NG tube. They will refuse to take orally. Okay, and these patients are considered to be not competent. Okay, they are considered to be in a psychiatric state, and therefore they are in a way forcefully fed through NG tube. They won't be, they will refuse taking anything orally. They will be like, because they are in a sort of kind of psychosis that it is. Depression, SSRIs, SNRIs, bupropion, all of those patient. And remember, SSRIs take 4 to 6 weeks to take effect. The patient starts SSRI, comes back after 2 weeks and says, this is not working for me, change to something else. Don't choose the option, change to bupropion or change to SNRIs. Continue the same dose for 6 weeks, the therapeutic dose that you started him on. Generalized anxiety disorder, SSRIs, SNRIs, as well as buspirone. Buspirone will be useful when the patient has which side effect of SSRI? So buspirone does not have what?
Sexual dysfunction.
Yes, correct. So bupropion, buspirone both don't have sexual dysfunction, and that's where you can use them for.
Bupropion.
Yes.
Bupropion.
Correct. Obsessive compulsive disorder, SSRI, the first line, and then venlafaxine and clomipramine. OCD should be differentiated from OCPD in the exam. This is the kind of question I will give you. OCPD patient will be egosyntonic. He believes that I'm doing the right thing. He believes, he won't present to you with the fact that he's doing something over and over again. His most likely concern for coming to your clinic would be maybe insomnia. He comes to you because he gets headache in the morning, and that's because of insomnia, but he does not find any problem with the fact that he is making lists for 6-7 hours of the next day schedule. He thinks that I'm doing the right thing. On the other hand, the OCD patient will be ego dystonic. He will rather say that, okay, I get these intrusive thoughts and I try to push them away, but I am unable to do so. And he will be continuously trying to get the thoughts out, and they will be doing the behaviors, compensatory behaviors that provide him relief. But he knows, he has good insight. OCD patients have good insight inside the disorder, that they have recurrent intrusive thoughts which they hate. All right, and OCD does not have that. Panic disorder, SSRIs, venlafaxine, benzodiazepines. But remember, panic disorder, since again SSRIs take time to be effective, 4 to 6 weeks. So patient in an acute panic disorder state, okay, if they give you both options, so what's the next step in management? One of the options is SSRI and the other option is benzodiazepine. So that will be benzodiazepine. In fact, panic disorder patients, when they're started, they may be started on SSRI as well as needed benzodiazepine for an acute panic attack, because SSRIs will take some time. And panic disorder has to be differentiated from two other disorders, which is agoraphobia and specific phobia. Okay, panic disorder the panic attack can occur anywhere, anytime. Okay, it does not have any typical associated with this stimulus, etc. Agoraphobia needs, it usually occurs at public places, okay, which might include elevators, which might include lines, in a grocery line, and it has association with that. On the other hand, specific phobia would be, patients might have the same symptoms of panic attack, but then that specific phobia will be only one situation. The bridges. Patient who feels having a lot of okay, so the patient with the specific phobia might have similar symptoms to agoraphobia and panic disorder, but that would be more related to a certain situation only, maybe just elevators, maybe just bridges. Agoraphobia, multiple sort of open places, and usually agoraphobia patients, they will restrict themselves to their home, and they won't have any symptoms or signs at home. All right. Panic disorder patient will be having panic attacks at home, anytime, outside home, during presentation. So it can occur anywhere. All right. Again, one more thing over here. Performance anxiety might have similar symptoms, palpitations and stuff, but that will be related to giving presentations in meetings and giving presentations. So there are so many overlapping symptoms and signs that you have to differentiate on the exam day because they can get confusing. Schizophrenia, you have to again keep in mind that if keep the timeline in mind. It could be 2 weeks, 3 weeks, brief psychotic disorder with, that is brief psychotic disorder, 2 weeks. And then 1 to 6 months, schizophrenia informed disorder, schizophrenia more than 6 months. But then one more thing that comes into the exam scenarios and where people make mistakes is when they are actually talking about schizoaffective disorder, right? Schizoaffective disorder, or maybe depression with psychotic features, bipolar disorder with the psychotic features. And to differentiate the schizoaffective disorder with the, a mood disorder with psychotic features, the psychotic symptoms have to be there without the mood symptoms in at least for 2 weeks. Patient might be hearing voices, but is not depressed, is not having the manic phase. All right, that would be schizoaffective disorder. And for mood disorder with psychotic symptoms, the psychotic symptoms will only be there when the patient is depressed, all right, or going through manic phase. So these things have to be the timelines, and these things have to be kept in mind.
Bilal, do you mean a mood disorder or major depressive disorder?
So schizoaffective disorder will include both bipolar disorder with psychotic features and depression with psychotic, so the mood symptoms in schizoaffective can be either of the bipolar type or depression. Schizoaffective is not limited to depression and psychotic features. Okay, it can be bipolar and psychotic features. That would also be schizoaffective. That's where some people end up making a mistake, that they think of schizoaffectives are only when they find depressive symptoms plus psychotic symptoms, and that's a problem. Bipolar disorder is also mood disorder, right? So bipolar disorder with psychotic symptoms, that can also be, if the psychotic symptoms are present without the manic episodes and stuff, so that would also be schizoaffective. Okay, so social anxiety disorder, the patient has anxiety in social situations. This will include in the work environment, there are a lot of people. Okay, while the performance only will be when he's actually performing, he's giving a presentation, that's mostly it. Performance anxiety only is when he's actually giving. If the patient has the anxiety and stuff due in the routine work in the office, that would be social anxiety disorder, or maybe with while meeting with friends and other stuff. On the other hand, performance only will be when he is performing. Again, don't
Bilal, how do you differentiate between specific phobia and performance anxiety?
Yeah, that's exactly what I was coming to. In specific phobia, a patient fears something, or some certain situation, but he doesn't have to perform anything over there. He is passing by a bridge and he gets palpitations every time he passes by a bridge. Okay, he might have heard of someone who died on the bridge or bridge collapse or something like that, and so whenever he passes through a bridge, he gets palpitations and symptoms. Patient afraid of cats. I have a friend who is afraid of cats. He sees the cats and he runs away. He feels like this cat is going to eat him up. He's a very brave person. He's a very brave person. Hello. So he's a very brave person. Otherwise, he has been living in conflict areas in the northern Pakistan. And back then, when things used to be bad, and things are good now. All right, everything is fine over there in the north. But back then, when there were, fightings going on and terrorism and all of that, and he has been through situations in which there were crossfire and all of that. And he lives in a mountainous region. He has been to glaciers and has been through, life and death kind of situations, facing animals, and he wasn't afraid. He sees a cat, and that is it. If someone, we were living together in the apartment, and I was like, I'm gonna bring a cat to the apartment. He's like, if you do that, I am gonna be out of this place. So that's the specific phobia. One thing, okay, the person exposed to that thing and gets symptoms of anxiety, all of that. Performance anxiety is mostly about giving presentation or a speech. All right, that's all it is going to be mostly on. All right.
Yeah. Got it. Thank you.
Okay. So Tourette syndrome, antipsychotics, tetrabenazine. Again, Tourette syndrome. What's the timeline? Should be there for at least one
For a
year.
year,
Yes, for at least 1 year, and it should include. Let's say a patient has vocal tics for 1 year. Is it Tourette syndrome?
no, it has to be both motor and vocal tics
Yes,
for
it
1
has to
year,
be.
which will
Yes, correct. It has to be
disable the daily activity.
correct. It should be both motor and vocal tics. All right. If it's just, maybe motor tics or only vocal or only motor tics, then that would be maybe persistent tic disorder, chronic tic disorder, but not Tourette syndrome. And Tourette syndrome is associated with increased risk, it has association with OCD, for example, ADHD and OCD. Okay, this is a patient who is feeling sad for 4 months. And he has symptoms of depression as well as he's hearing voices. 7 months back, it was the time when he heard those voices. It was 7 months back. You see on examination, you will get the slow psychomotor retardation, thought blocking, and stuff. So this patient diagnosis would be correct. This would be schizoaffective. This patient has.
Yeah.
So this patient has all these.
Schizo.
Yeah, this patient has the depressive symptoms with psychotic features for the past 4 months, but 7 months back was the time when didn't have mood symptoms, but was hearing voices. All right. So this patient has schizoaffective disorder. So brief psychotic less than 1 month, schizophrenic from 1 to 6 months, schizoaffective and schizophrenia and mood disorders, both major disorder or bipolar. That's where most of the people make mistake. When it's bipolar disorder with psychotic, patient has a history of hearing voices and then also has a manic episodes at some other point in time, that would be schizoaffective. But people do not end up because they associate schizoaffective with only depression. That's the mistake people commonly make on the exam. So more than 2 weeks of psychotic symptoms without a manic or depressive episode. Delusional disorder, patient is, everything is fine except one or more than one delusion. All right, delusion only. And to differentiate delusional disorder from maybe schizophrenia, this patient is not hearing any voices. Okay. On exam day, a question, if he mentions that it's a typical belief. Okay, the patient is, patient thinks that celebrity is in love with him, or his wife is cheating on him, or spouse is cheating on him or her, and so that will be usually on exam day. It's only one delusion. That's how they test you on more than 1 month, but there won't be any psychotic symptoms. So on examination, the patient won't have any of these things. All right. Blunted affect, apathy, anhedonia, disorganized speech. So he's a normal guy, appears normal, but thinks and they have to be culturally incongruent. People might show up from South Asia thinking that they're having joint pains or knee pain because of losing the joint fluid through maybe semen, for example. All right. And these are culturally sort of kind of things where people affected by cultures. So this is something that is contrary to the cultural beliefs and all of that. And again, a patient comes to the clinic with accompanied by maybe there is a mother and a son. Okay, the mother thinks that she has been gifted with some certain powers. Okay, and the son also believes so, that his mother has some special powers. Okay, everything is fine. That will be folia do. Okay, where the mother and son are sharing the same delusion. Okay, or mother thinks somebody is after them, and the son agrees with the mother. Okay, that's the kind of thing that could be. And schizotypical personality disorder. Um, Again, the typical patient on exam scenario will be wearing weird clothes, magical thinking, may have some delusions, aliens are, aliens kind of thing. So that are less frequent and less severe than in schizophrenia, less effect on the functioning. Patient was using paroxetine or maybe like sertraline, and then suddenly stopped using it, and now has developed flu-like symptoms, flat headache, insomnia, vivid dreams, gait instability, sometimes a shock-like sensation through the spine. This is so I think they haven't mentioned it in the FA 2021. It was back there and then. It's antidepressant discontinuation syndrome, with especially the short-acting antidepressants like sertraline, paroxetine, etc. Fluoxetine is long-acting, relatively long-acting, the longest acting of all, and it's less commonly associated with the antidepressant continuation syndrome. But the short-acting ones like sertraline, paroxetine, they can have people, the patient developing the symptom withdrawal symptoms as early as maybe 3 to 4 days, 4 or 5 days, and they can, if they suddenly stop. So these patients will be, the treatment will be to start them on the medication again and then slowly taper them off over the period of maybe months sometime. So we don't have it here, the withdrawal syndrome. One more thing about major depressive disorder, and when you have to differentiate it from maybe persistent depressive disorder or adjustment disorder or cyclothymic disorder. So if you see a exam question where the patient fulfills the criteria of major depressive disorder episode, that is it. Okay, if he is not fulfilling the criteria of major depressive disorder, maybe has 2 or 3 of these symptoms, maybe just low energy and sleep disturbances, that won't be then major depressive disorder. And then you might think about cyclothymic or persistent depressive disorder. Persistent depressive disorder or cyclothymic disorder patient would not have the entire criteria of major depressive disorder, won't be having more than or equal to 5 of these symptoms. It's only when it's less than 5 when you think about. So if a patient presents in a postpartum patient and has more than or equal to 5 of these symptoms, it won't be postpartum blues, it will be major depressive disorder with peripartum onset, for example. Okay, and patient had a recent maybe started a job and has 5 or more than 5 of these symptoms, that won't be adjustment disorder, that will be major depressive disorder. You think of the other disorders when the symptoms are less than 5. Okay, as soon as you reach 5, that's it. Okay, again, then with 5 or more than 5, you can think about major depressive disorder with psychotic features, schizoaffective disorder, bipolar disorder 2. Okay, for bipolar disorder 1, you don't need a major depressive episode, but for bipolar disorder type 2, you need a major depressive episode as well as a period of hypomania, okay, for at least 4 days. But for bipolar type 1 disorder, a manic episode is all you need. Okay, 7 days of all those symptoms unless hospitalized. Patient may get hospitalized on the 2nd day of having all those typical manic symptoms, but that still would be a manic episode. Okay, there will be significant functional impairment and the patient will get admitted, will be started on medications and will be fine. That's all you need to diagnose bipolar type 1 disorder. Okay, you don't need a major depressive disorder episode. Patient has delusions, decreased need for sleep, distractibility. Okay, and you're starting him on a drug, the first line drug, let's say. But what labs would you like to do? 2 labs. Let's say you diagnose him with bipolar type 1 disorder. Okay, and you start him on a medication. What medication is that most likely?
Lithium.
Lithium, correct. So what labs would you do? Baseline labs.
Renal function.
Renal function
Uh,
and TSH, right?
yes, that's, yeah.
Yes, lithium can cause hypothyroidism. So you will do these 2 labs. Let's say you do renal function testing, you find that creatinine is 2.5. What drug would you give to this patient? Would you keep him on lithium, or will you switch to something else?
Ask
So-
to limit regimes.
You will switch it to most likely valproate.
Valproate.
Yeah. Okay. So bipolar disorder type 1, you see plus minus a hypomanic or depressive episode. You don't necessarily need a hypomanic or depressive episode. Okay, but one manic episode is must, at least one. And bipolar type 2, when you need a hypomanic and a depressive episode. A hypomanic episode itself is not bipolar 2. You know, by a hypomanic episode where people feel they are very functional and doing things properly. Interestingly, when they are talking about a manic episode, it's an episode with the severe functional impairment, person spending everything left, right, center, okay, and then delusions and all, and get to be hospitalized. Often for hypomanic episode, that will just talk about a patient who is more productive. All right. And without depressive episode, I'm sure a lot of us might have those kind of episode where 3 to 4 days of we have a lot of activity, like productivity, you know, people, you know, maybe, but since there won't be a depressive episode, major depressive episode. Similarly, when you're starting your patient presents with depression and has you want to start him on SSRI, you have to screen for an episode of a past episode of mania or hypomania. All right, because that otherwise the SSRI can trigger that episode. Okay, so lithium, valproic acid, carbamazepine, lamotrigine, typical antipsychotics, and cyclothymic. Now you have mild depressive, you know, not major depressive. Keep that in mind. Hypomanic and mild depressive, less than 5. You know, fluctuating, must last at least 2 or more than 2 years. And this would be similar to, in terms of timeline, it will be similar to persistent depressive disorder, because it has to also to last for at least 2 years, with any remission lasting less than or equal to 2 months. So persistent depressive disorder and cyclothymic disorder, they're similar in terms of timelines. Where are we? Yeah, and you know, in terms of like 2 or more than 2 years, remission less than 2 months, and that's it. And yeah, lithium can cause hypothyroidism, tremor, hyperthyroidism, polyuria, nephrogenic diabetes insipidus, teratogenesis, abstain anomaly, the atrialization of the right ventricle. And you have to closely monitor it. Almost exclusively extruded kidneys, and certain drugs can increase the concentration, for example, thiazides, especially thiazides and NSAIDs, and they can cause lithium toxicity. So key that, especially thiazides, that is probably something that they might test you on the exam day. Okay, so middle-aged man has strange behavior. You can, he gets undressed in office in where he works, makes remarks, you know, sexual remarks to female co-workers, and has come to you and Babinski reflex is positive. He has difficulty with finding words. The diagnosis here is, this is maybe like 60-year-old man with all this behavior.
FTT.
Yes, frontotemporal dementia with, because frontal lobe is involved in disinhibition. In inhibition, yeah, frontal lobe is involved in inhibition. So when you have selective frontal lobe degeneration, the patient gets disinhibited. All of this kind of behavior can be expected. Formerly called pig disease, and associated movement disorders, aphasia. So frontotemporal region has the region for so Wernicke area, Broca area. So that's where the problem lies. So they might have trouble with speaking, etc. So frontotemporal lobe degeneration, and they will have inclusions of hyperphosphatidate tau or ubiquitin TDP bodies. People might end up mixing all of these up, all of things here, in Alzheimer, frontotemporal dementia, Lewy body dementia, Parkinson disease. So it's important to. So for example, neurofibrillary tangles are intracellular. And the plaques are senile plaques are, they're extracellular. Okay, so you have to keep that in mind. Which ones are intracellular, and make sure you Google these pictures for all of these. How do Lewy bodies look like? How do peak bodies look like? How do tangles look like? And how do the plaques, senile plaques look like? Again, Alzheimer's disease. Well, you guys already know, increased risk in Down syndrome, early onset Alzheimer. One thing that I'd like to stress upon over here is when it comes to the familial Alzheimer's disease, the E2, the E4 mutation is associated with increased risk of sporadic form. By sporadic form, it means Alzheimer's disease that starts in, when does usually Alzheimer's disease begin? On average, maybe 70-year-old, 75, 80-year-old. So increased of sporadic form with patient with, if there's a family history of a lot of people having Alzheimer's disease starting in the 70s, 80s, that is ApoE4 mutation. However, if there is a family history of people, family members, relatives having developing Alzheimer's disease at age 40, 45, 50, that is mutation in presenilin 1, presenilin 2, APP. These are the mutations in earlier onset forms. So both increase, APE4 and presenilin 2, 1, 2, increase the risk of, and they have family history and the risk of Alzheimer's disease. But the presenilin 1, 2 is associated with the earlier onset. So 50 year, 45 year, 50 year, if that's the age the family members are developing Alzheimer. Patient has his.
Can you go to previous?
Sure.
So Lewy body dementia, only Lewy bodies, they haven't any hyperphosphorylation or tau protein is known.
So they only have Lewy bodies, all right? And Lewy body dementia has to be differentiated from Parkinson disease on the exam day.
Parkinson disease.
Yes, so Parkinson disease and Lewy body dementia both can have Lewy bodies. The difference will be that in Lewy body dementia, you will have onset of Parkinsonian symptoms and dementia within 6 months. All right, a patient develops, let's say patient develops hallucinations and dementia at age 56 years, and then within 2 to 3 months has those, bradykinesia and tremor, resting tremor, all of those findings. Or maybe a patient has developed, is diagnosed with Parkinson disease, with all those findings, tremor and bradykinesia, akinesia, rigidity, all of that, and comes back 3 months later with the hallucinations and dementia and all of that. the diagnosis would be Lewy body dementia, not Parkinson disease. Parkinson disease, patient has Parkinson, develops Parkinson disease at age 56. At age 60, let's say, develops hallucinations and dementia. That would be Parkinson disease with dementia. Dementia secondary to Parkinson disease. So it has to be more than 1 year, the difference in the cognitive and motor symptoms. But if they occur within 1 year, 5, 6 months, 4 months, 7 months, that would be Lewy body dementia. This is how you differentiate it. Otherwise, they will have similar manifestations, Parkinsonism as well as hallucinations and dementia. All right. Patient has a major depression. You start him on a medication. Now develops pressured speech, distractibility, okay, and talkative, not sleeping much. Diagnosis is so this, you started patient on SSRI. Let's say the patient had depressive symptoms. You started him on SSRI. He comes back to you after 2 weeks and tells you this is a magic pill. I feel great. I am so productive. I'm starting a new company and we are gonna,
Yeah.
challenge Microsoft and Apple and all of that. And he's thanking you profusely and has brought you gifts, for starting him on that magic pill. Diagnosis is
Bipolar.
Many.
yes, this is bipolar disorder. And you probably use SSRI or SNRI, all right? Can be SNRI or SSRI. And one more ethical segue over here. While it might be okay to accept gifts from patients, of low value, $50, less than $100 usually, you cannot accept gifts from anyone who has psychiatric illness. Okay, patient with mania brings you, let's say, $50 or $100 pen. You won't take it. Okay, you will thank him and refuse it and just tell him, sorry, I cannot take it, because the patient has clouded thinking, is in a manic episode, in a psychiatric. So it's never okay to receive gifts from psychiatric patients. Okay. Similarly, it's never okay to initiate a relationship with your current psychiatric patient or a previous psychiatric patient. Even though maybe for 2 years you haven't been, because it's easy to exploit for the physician. So and of course the physician has access to the sensitive information. So these things have to be kept in mind. So could be SSRI, SNRI. Their side effect that might actually that is important from the exam point of view is increased blood pressure. They're sort of stimulants and they can increase blood pressure, and they have various diverse applications. Diabetic nephropathy, and then you have fibromyalgia where you're using duloxetine and milnacipran, and depression, generalized anxiety disorder, diabetic nephropathy. All right. Patient started on trifluoperazine and develops akathisia. And then you switch him to another medication and he comes back and tells you that he has developed drowsiness, blurred vision, dry mouth. So what drug did you switch him to?
Atypicals.
Atypical.
Anticholinergic.
Anticholinergic side effect.
So actually over here, what so the patient was actually taking a high potency typical antipsychotics, okay, and you switched him to low potency typical antipsychotics. So let me show you the over here. Where do we have it here? So typical antipsychotics, they are associated with the high potency typical antipsychotics associated with extrapyramidal symptoms, and low potency typical antipsychotics have antihistamine and alpha-1 adrenergic and antimuscarinic effects. Okay, that's what. So usually high potency, low potency stuff is not important on step 1 point of view, but keep benzodiazepines and antipsychotics. keep their the difference between keep that in mind, which drugs are high potency, which are low potency. High potency associated with extrapyramidal symptoms, low potency associated with alpha-1 antinergic, antimuscarinic, antihistaminic side effects. Similarly, which benzodiazepines can be used in liver failure, right?
So, excuse
Over.
me, there was a question, what was the diagnosis?
So this patient was earlier started on a high potency typical antipsychotic and developed akathisia, all right? Extrapyramidal side effect. Do you switch this person to low potency typical antipsychotic and now has antihistamine and this is anticholinergic, antimuscarinic side effects. Maybe he might have orthostatic hypotension as well, all right? Dizziness maybe upon getting up. So this patient was earlier on high potency and low potency, and you probably need to switch him to atypical antipsychotics. Atypical antipsychotics, the important ones usually on exam point of view are especially risperidone for causing what? Hyperprolactinemia.
Experimental.
No, so risperidone is known for, it's known for hyperprolactinemia. All right, rest of the atypical antipsychotics are not known for that, as opposed to the typical ones like haloperidol, etc. They can cause so hyperprolactinemia in the atypical class is with risperidone. Okay, the another one is important one is clozapine. Agranulocytosis patient with refractory schizophrenia. You tried multiple medications, didn't work, started on new medication, comes back after 3 weeks, has fever and hypertension and sepsis, and then you do blood, you do a CBC, and then they'll show low neutrophil count with normal other WBCs. So normal or raised in other WBCs. So agranulocytosis with clozapine. And clozapine also with seizures. Keep that in mind as well. Sometimes the patient might present with seizures after being started on the drug, after being diagnosed with treatment resistant. So these clozapine is important. The way they might ask you when it comes to thyroidazine is maybe fundoscopy. You may do a fundoscopy before starting the patient with thyroidazine. And yeah, olanzapine is also important in terms of weight gain. You may give this to the patients with severe weight loss. Okay, losing a lot of weight due to psychosis. So that olanzapine might be good for them. And so their side effects also direct you to do certain labs depending on the drug that you're prescribing. You're starting him on prescribing, they might ask you what labs you want to do, CBC count, and you might want to repeat that after 2 weeks or a month or 6 weeks. You're starting a patient on olanzapine, do lipid profile and glycemic HbA1c level, and then repeat it after on the follow-up visit. Okay. Yeah. So, and the extrapyramidal effects, how do you treat them is also important. Okay. So patient with acute dystonia, they might not give you benztropine in the options, but diphenhydramine. A lot of people might not really think of diphenhydramine as something which is a treatment for acute dystonia, right? Something antihistamine for acute dystonia. Are you kidding me? That's the kind of thought people might have. So that might be over there. Similarly, beta blocker for akathisia, restlessness. People might not think. So people think of benztropine, of course, but the other medications people might not really. And tardive dyskinesia, you don't use benztropine. So benztropine can be used in all three except tardive dyskinesia, and often you have to discontinue the medication, or you can try when deutetrabenazine, valbenazine. Okay, all right. Which drug won't you give to a patient with a history of eating disorder? Which antidepressant is contraindicated in a patient with a history of eating disorders? It is
SSRI.
SSRIs, all SSRIs. or maybe SSRIs, are SSRIs really contraindicated in the patient with history of
Anorexia nervosa.
no, it's not contraindicated. So SSRI is not a treatment for anorexia nervosa, acute anorexia nervosa, but the patient with a history of anorexia nervosa in the past presents with depression symptoms, you can start on the SSRI. Which atypical antidepressant is contraindicated?
Bupropion.
Yes, bupropion. Bupropion is contraindicated in patients with history of bulimia and anorexia nervosa because that can cause seizures in these patients. So that, you know, that's what to keep in mind. That's the high yield point when it comes to STEP. That's the kind of question they like to ask you. And of course, it does not have sexual side effects. So that is one more. And third thing with smoking cessation. Patient with depression trying to quit smoking but cannot quit, you know, does not have motivation to quit smoking one of antidepressants. So you may have to kill two birds with one stone. You may use bupropion for patient with smoking cessation and depression. Mirtazapine, weight gain, okay, and sedation may well be useful in patients with insomnia and weight loss. All right, that's pretty much where you would like to maybe use it. Trazodone, again, this is what they're going. Priapism is the one they're going to give you a question. Okay, patient. So when it comes to these typical with their mode of action, so you know, like trazodone, 5-HT2, alpha-1 adrenergic, H1, mirtazapine, 5-HT2 to 5-HT3. So I didn't really do all of these in great detail. You know, 5-HT1A, 5. So serotonin receptor subtypes. I didn't get any question or exam day, and I probably think it's not very high yield. You know, but might actually be high yield is that the typical relevant stuff. You know, priapism for trazodone. And you know, actually, trazodone is not given for depression. Of course, they have mentioned it for a typical depression. This is usually used for insomnia. Yeah, it's used primarily for insomnia, and of course the side effects, and because you know it's and the reason you use it for insomnia is because of its H1 receptor effect, and the reason it can cause postural hypotension is because of alpha-1 adrenergic blockade. So their mode of action correlates with their side effects and their indications. Vernicalline, smoking cessation, that's where you bring it. And then partial agonists. These they can give you questions with graphs in which you start him on a medication, and then the efficacy has been reduced by half. Okay, so the partial agonist, you know, what antipsychotic is partial agonist? Aripiprazole, right? Aripiprazole is they have they mentioned over here. Aripiprazole. Yeah, aripiprazole is a D2 partial agonist. Okay, this is where they might, you know, dive all into basic pharmacology and partial agonists, etc. So varenicline for smoking cessation. Vilazodone and vortioxetine, probably not very you know, high yield, except there's serotonin syndrome like effect. All the drugs that can cause serotonin syndrome, you know, linezolid, tramadol, all, you know, and multiple others, they are very high yield. Okay, so the psychiatric emergencies, including neuroleptic myelination syndrome, serotonin syndrome, how to differentiate between them is important from the exam point of view. Okay, there's a resident who receives negative feedback from attending, later goes yells on a medical student. Which ego defenses is it displaying?
Displacement.
Correct. Yeah. So displacement one here. Okay, there's one more thing about displacements you have to keep in mind. Sometimes it doesn't have to be a neutral person, rather it can be only a neutral object. For example, this patient goes back into his house, goes to his basement, and he goes around breaking things or kicking on a punching bag and feels good. That would be displacement, but people might confuse the punching bag thing with what? Sublimation. You know, a patient goes back home, kicks the punching box and feels good, that would be displacement, not sublimation. In sublimation, you do something that is useful in your career. Okay, patient has anger and aggression and applies that into maybe excelling in sports or joins the military. Okay, or a patient has thoughts of stealing or killing and violent, and starts writing books on crime and becomes a great writer. That would be sublimation, where you channel your energy into something that is in terms of your career, is productive in terms of your career. That would be sublimation. But if somebody just goes back, kicks a few times on the wall or on a punching bag, that would just be displacement. Okay.
How would you differentiate it with acting out? Because acting out is also, if you have negative thoughts, you are doing like throwing things and everything like that.
Usually acting out would be in front of people. Okay, this will relate to acting out will relate to doing actions to that another person is involved in that, in the entire frame of action. Patient with the displacement goes into the displace. You might have seen Facebook videos where they offer you a house where there is old furniture and you have to pay $50 for an hour, and all you do is go there and break things. Have you seen those kind of videos where people with their anger and stress, they relieve that by paying a nominal fee for going to an old building and breaking things around. So see the when the patient goes around, breaks things in his own property and stuff, that would be something else, as opposed to maybe acting out where the patient is being stressed out and has emotional conflict, and he starts taking actions that involve another person in the loop. Okay, so this patient is skipping therapy appointments with the therapist, okay, to avoid dealing with his past. So he's taking an action and he has therapist is in the loop. All right, so that's how acting out will be different from displacement. As well as one more thing that we bring in over here, which is something not a different thing: intermittent explosive disorder. A patient who has sudden feeling of rage and anger and cannot control his anger, goes around, breaks things, hits people, and later feels remorse, later feels bad about his behavior. That's the typical clue on the exam. The patient will feel bad about his behavior but cannot control it when he feels that anger, as opposed to maybe person with antisocial personality sort of goes on breaking things, unlawful stuff, is not remorseful. Okay, but intermittent explosive disorder patient will be remorseful about his behavior, and it's just that he cannot temporarily control himself when that is going on. Okay, so again, fixation and regression sometimes come into point. So fixation, when someone remains at a more childish level and does not go beyond that. For example, a surgeon throws a tantrum in the operating room because the last case ran very late, and this is probably something that surgeon always does. Okay, as opposed to regression, and regression is again more usually in the children. That's how they will text on an exam, where a 6-year-old suddenly starts bedwetting after a stressor, had a and had an episode of physical or sexual abuse or any other reason of stress, and now starts bedwetting again. So going back on the milestones is usually what's going to be regression. And fixation is a certain part of the behavior that the person keeps on displaying. It becomes a part of the personality. Okay, these are small differences, and of course one has to be very vigilant about these little things. But I won't, and usually the questions were clear in regards to yeah. Idealization. in which you don't, these are typical supporters of political parties and militaries, where they find only positive thoughts or someone, and not having any any flaws. Typical political party supporters, they don't find any problem with the political leader. Okay, and they find the consider him is perfect in every regard and every term. Identification. Mhm.
Idealization, just think only positive things.
Yes, you think your leader is great, has absolutely no flaw. If someone thinks, that the leader, their political leader, has all the good traits in the world and has absolutely no flaw, he's
Okay.
like a angel. That's the kind of devotion people are paying. So these are the people who follow cults and stuff. They idealize the typical the leader, and they think of him in an extremely positive manner without looking into any flaws. Okay. Similarly, some football fans, who follow football and certain clubs, Chelsea and all of that, and they have that typical, they're all good and then the best and all that, and everybody else is useless. And okay, so idealization, you differentiate it from what? Splitting. So in splitting, you divide the world into two kind of things. Something is all good and the other thing is all bad. Okay, physicians are all good, nurses are all bad, or nurses are all good, physicians are terrible, and they're absolutely useless. Okay, splitting seen in bipolar personality disorder, in which everyone is either good or all bad. Okay, and idealization is only limited to extremely positive thoughts about someone without any negative thoughts. Okay, identification is unconscious assumption. Keep that unconscious assumption in mind, because it's a immature response, right? Identification is one of those immature responses. It's unconscious. Someone finds his mentor, or someone's mentor has a certain schedule or a certain way of doing things, and he follows it deliberately, and knowing that he's following it, that would not be identification. Identification is largely unconscious. They have given an example. The resident starts putting her stethoscope in her pocket like her favorite attending, instead of wearing it around her neck like before. And this is not happening because she has appreciated it, that the attending is wearing it, is putting it in the pocket, and that's, I'm following her and something. It's unconscious, without even thinking about this, and of unconscious assumption of characteristics, qualities of or traits of another person or group. Again, intellectualization and rationalization, these are two things people end up confusing. Rationalization is justification. All right. Someone didn't get into maybe law school, and thinks that the liars, they have a very terrible lifestyle either in any way, and they are not doing they are doing the illegal stuff and all of that. So someone who is justifying something bad that occurred. Okay, someone who was fired, who thinks the job is not important anyway, for example. Intellectualization is, on the other hand, getting obsessed with the facts and figures and the scientific aspect of something, as opposed to the emotional aspect, to avoid facing that emotional thought process. So a patient who has been diagnosed with cancer discusses pathophysiology of disease, or goes back into the library, and all day he's reading papers and research and new research, latest research, thinking about the facts and figures. Okay, what's happening on, how many are surviving, what new research trials are going on, and that's all he's thinking about. Okay, that would be intellectualization. Or someone else who's a physician, who goes on to, instead of thinking about his own pathophysiology, goes back to work, and wants to keep himself busy with the x-rays and lab reports and everything. That is intellectualization. Isolation of affect, separating feeling from ideas, events. Someone is describing murder in graphic detail with no emotional response. No, or someone who's a witness of a murder of a close friend maybe, and then explaining it. Okay, they came over and yeah, then they took a knife and they, this is how they took a knife and then they, just killed my friend, and then we took the friend away, and we this is the how the person described without any emotional, without the affect. Basically affect is how you're describing something, the mood, the emotional aspect of the, when you're talking about something. And this has to differentiate from well, not much, I think. Sometimes repression. Okay, the patient with repression does not remember it, okay, that it ever happened. Passive aggression, again, when wherever there is a hierarchy and the person cannot express the discontent or negative feelings or disagreement with the higher authorities or even colleagues, when the environment stifles any open discussion, and these patients will go on to do behaviors that will be indirectly, basically they are showing an opposition. Employees late to work, or someone, a boss gives you work to do, and you go back home and you're angry that you don't want to do that work, this is not your job, and you have been repeatedly receiving the work and you don't get enough time, and you go back and tell the boss that my wife is in labor, okay, and uh, you know and that you cannot do the appointment. And then the next day again you tell him my wife is in labor, and the other day. So yeah, all these kind of, or for example, maybe there is a colleague in the work environment who doesn't shower, for example, and smells all the time, and someone, before he shows up on his desk in the morning, someone takes a soap and shampoo and perfume and places it on his desk, all right, as a reminder to use this, to basically to somehow make him realize that he doesn't shower. So that would be passive aggression as well, right? Without directly confronting someone is using these kind of means. Projection, again, people make a lot of mistakes when it comes to projection, and somehow they mix it with the reaction formation. Yeah, mostly reaction formation. So patient with projection, yeah, people also confuse it sometimes with the mix it up with the, I think, displacement. Yeah. So projection, where someone who has a bad impulse accuses others of that one. If someone wants to cheat, accuses his spouse of being unfaithful and a cheater. Someone who has sexual feelings towards their colleagues, let's say someone who has a female friend and he has maybe sexual feelings toward the friend, and rather goes on telling her that she has sexual feelings toward him, all right. So again, projection, because he has the thoughts about that person, and instead tells her that she has the thoughts about him. Or similar kind of scenarios, someone who wants to be someone who thinks of himself as a failure, accuses his wife of thinking about him as a failure. Okay, so these kind of things. Rationalization, talk about the reaction formation, doing something opposite to what the person is thinking about. Someone who feels like, who has homosexual thoughts, and but he's not comfortable with it, and instead joins a group of people who are and who are homophobic, who are against homosexuals, or someone, okay, someone who has repeated sexual thoughts goes enters a becomes a monk, um, and similarly, a stepfather treats the child he resents with excessive nurturing and overprotection. Okay, someone dislikes their teacher, but they end up, being very sweet and kind to them. So this kind of stuff. Okay. So regression, talk about that. Going back, turning back the clock. Well-trained child starts evaluating again. Repression, involuntarily withholding an idea or feeling from conscious awareness. Basically, patient would not simply remember it, and it's not just the patient is saying that he does not remember; he actually doesn't remember. Someone, female with a history of sexual abuse, documented sexual abuse, maybe, who was reported elsewhere in the childhood, now simply cannot remember it. So that would be repression and splitting. We talked about that earlier. Dividing the people between all good or all bad, and they're common in modern personality disorder. That's how they mature defenses, in which someone is using a mature way to deal with the stress and unwanted feelings. Sublimation, talked about earlier. Someone who channels his negative thoughts into something, career. Maybe someone who has a lot of sexual thoughts becomes a world-renowned porn star with billions and millions of dollars in his account. Someone who has aggression and joins martial arts, right? Someone who feels like hitting everybody joins martial arts or MMA, mixed martial arts, or maybe military, police, writing. So of course, you can, anyone who becomes a great, excels in their career by channeling their, okay, altruism, generosity. Okay, someone who has guilt about what they do and then do a lot of generosity to alleviate that feeling. Someone, for example, mafia boss, or someone who steals and all of that, and then starts making donations. Expression, voluntarily or intentionally withholding an idea. Like, don't worry about your step 1 exam until it's nearby. In fact, don't worry about that even when it's nearby. Just keep working and you'll be fine. Don't worry about it even on the exam day. And humor, lightheartedly expressing, yeah, this is again simple thing. People joking about their exams and boards, and it's a lot of people that do display humor, and that's what the social media is doing all this. People about their all the memes are a lot about that. Models of change, important, very important from exam point of view. And the so patient has alcohol abuse, has pancreatitis, and he says that, okay, I think this might be due to alcohol, but I don't think so I can cut it down. This patient is at stage of, so
Contemplation.
yeah, contemplation. What if he says, I don't know what should I do to cut it down?
It's like ambivalency.
So what I'm trying to do over here is, sometimes people might actually be, they want to change and they're planning for change, but they don't know how to change. That would still be in preparation or determination phase. Let's say the patient wants to lose weight. Okay, patient has a history of diabetes and everything, and now wants to lose weight, and comes out to the physician and says, I am, I want to lose weight. I don't know what kind of exercise I should be doing. maybe he just wants to more information and more guidance on the, but that would be still preparatory phase. If the patient refuses to change, that would be the contemplation phase. Refuses or ambivalent. Okay. Ambivalent means, he thinks he won't be able to do it, probably. Preparation is planning for
What you
change.
explain? Can you again slowly? Is compilation?
So preparation, determination phase, a patient who says, okay, I think my problem is because of this, and I don't know about the ways to change my, I don't know how to cut my weight, cut down my weight. I don't know what kind of exercise I should be doing to reduce, decrease my weight. The moment you tell them, okay, you do have to do this exercise, that exercise, and the patient goes back and start doing that exercise, that patient is in preparation phase. The patient in contemplation phase is unwilling to change, or thinks he won't be able to change. He acknowledges problem, but is ambivalent and unwilling to change. On the other hand, the patient in preparation, of course, it's a simple question, who is committed and planning. But even the person who is asking for ways to change, asking for methods to change, is asking for advice, what kind of ways should he be using, is also in preparation or determination phase. Because he's planning, he's asking you for ways to do it. If he says, no, I cannot do it, I might think about this in future, but I cannot do it right now, that would be contemplation. Is that clear? But I'm trying to make sure you guys understand. Of course, the rest of it is simple, relapse, pre-contemplation is simple, maintenance is, action, willpower. But these three things, in fact, pre-contemplation, contemplation, and preparation, these will be the ones that will usually test in an exam. And again, pre-contemplation is simple, simply says, denial. Patient thinks I don't have any problem. I'm fine, totally fine. This is because of something else. And then contemplation and preparation, these are two things where you have to make sure you don't go for contemplation if it's actually preparation. Okay. Impaired short-term memory, 46-year-old woman, and there is primarily medial temporal lobes and hippocampus that are atrophied. Diagnosis is so this is Alzheimer's, and sometimes they might not even give you any MRI changes. They might just only tell you, okay, there's atrophy of hippocampus and just medial temporal lobes, because that's where it starts. Hippocampus is probably the first place where you first see the changes of atrophy in Alzheimer's disease, and it's Alzheimer's disease, and you can use all those treatments. Donepezil.
This is Alzheimer.
This is Alzheimer's disease. This is Alzheimer's disease.
Yeah.
And this is early onset. This is early onset.
Early onset.
Either this patient has Down syndrome, and if she does not have Down syndrome, then this is a presenilin 1 gene mutation, presenilin 1 or presenilin 2.
Which one?
Presenilin 1. Yeah. It's not here, but I did talk about that earlier. That presenilin 1 and presenilin 2 genes are associated with early onset Alzheimer. On the other hand, the ApoE4 is associated with sporadic or late onset Alzheimer's. Okay, keep that in mind. This is presenilin 1 gene mutation, not ApoE4. ApoE4, if this patient has a strong family history and develops Alzheimer's, symptoms of Alzheimer's and everything in 80s or 70s, late 70s. Okay, that would be the ApoE4 gene mutation. Okay, so diagnosis and for treatment, and this is progressive disease. You're not actually treating the disease, you're just decreasing the symptoms. They don't affect decrease disease progression. And the first line is the acetylcholinesterase inhibitors, and the second line, if the patient is still having symptoms and everything, the second line will be memantine, which is NMDA receptor antagonist. NMDA is what? NMDA is glutamate, right? People are often confused about what is NMDA and their antagonist and agonist and all of that. So NMDA is glutamate. So moderate to advanced dementia, hallucinations, dizziness, and confusion. And over here, you don't give them to the patients with cardiac conduction abnormalities, because they will increase the parasympathetic flow, right? And parasympathetic system can cause, it will basically inhibit the conduction in the heart, right? So you won't give patients with the cardiac conduction abnormalities, you won't give them these donepezil, rivastigmine, galantamine sort of drugs. As well as you won't give them, other drugs like beta blockers, calcium channel blockers, etc. And you don't give beta blockers and calcium channel blockers, etc. to patients with Wolff-Parkinson-White syndrome. Patient develops atrial fibrillation, has history of Wolff-Parkinson syndrome. You don't give them nodal blockers because that will increase the activity of the accessory pathway. And, yeah. So, okay. And ALS, riluzole, again, it is sort of NMDA antagonist. It will decrease neuron glutamate excitotoxicity, and it will increase survival. And Huntington disease will decrease dopamine release and packaging, and tetrabenazine, and tardive dyskinesia with tetrabenazine, deutetrabenazine, right? That's what we read earlier over there. Okay, so a college boy has dilated pupils, typhosis, hypertension, high blood pressure, all of that. This is which intoxication?
Okay.
Cocaine.
Okay.
Yes, cocaine. This is cocaine intoxication. And what's the treatment for this patient? How do you manage him? So you will give him benzodiazepines, okay? No alpha blockers, no beta blockers. And you need to do a urine test, okay? Urine toxic screen, okay, to confirm the diagnosis. One more thing, if the scenario also mentions hypotension, hyponatremia, then it is
Ecstasy.
ecstasy, correct. Ecstasy will have everything over here except so it will also have hyponatremia. So yeah, we're talking about cocaine. It blocks reuptake and will cause dilation, diaphoresis, hallucinations. And chronic use may lead to perforated nasal septum, vasoconstriction of the nasal septum. Again, when it comes to nasal symptoms, the other thing you have to keep in mind is inhalant abuse. If there is a rash around the nose, eczema or rash around the nose, and short episodes of parents finding their child where looking like a drunkard, someone who has ataxia, falling around, poor gait, that will be inhalant abuse if you see the rash. So rash over here and rash in the inhalant abuse and septal perforation and cocaine. In fact, you can see Google pictures of the septal perforation and in cocaine, and you would see a lot of those. And the treatment is benzodiazepines. You don't use alpha beta blockers, etc., or beta blockers, a mixture, all of that. Leave it alone. Okay, just do benzodiazepines and manage them symptomatically, and they will be fine. Once the cocaine effects, they go away. And of course, when you have cocaine withdrawal, you will have hunger, severe depression. So stimulants, they decrease appetite, right? Cocaine, amphetamines, modafinil, etc. Stimulants will reduce the appetite. Okay, so non-specific will reduce appetite. So when there is withdrawal, you will have increased hunger. Okay, when it comes to cocaine, for example. Similarly, nicotine as well. You get increased appetite and weight. So a smoker trying to quit comes back with increased weight, and he says, I can't do this. By increasing weight, it is putting me at risk of heart disease and stuff. So what do you tell him? There are other healthy ways to reduce weight instead of smoking. Caffeine. So intoxication can cause palpitation, agitation, tremor, insomnia, and interestingly, sometimes people taking a lot of caffeine for a certain event or presentation, like someone has to give a presentation and wants to be mentally very sharp during the presentation, a lot of caffeine, it ends up causing performance anxiety or exacerbating it. This patient might actually end up having tremor and palpitations, and this will rather destroy the original purpose of having a great presentation. And caffeine withdrawal, all of us have experienced it. Anyone who so headache, difficulty concentrating, flu-like symptoms. Headache, especially those people with migraine, if they are taking I have trouble with migraines, and if I don't take tea, okay, I don't use coffee. Back you used to use coffee back then. I only use tea. But if I stop taking tea for a day, it's a sure guarantee of for me of the return of the migraine. So I take 2 cups of tea every day. And yeah. Okay, amphetamines, pupillary dilatation, grandiosity, euphoria, hyperalertness, paranoia, skin excoriation with the methamphetamine use. I think that's because of the itching and the feeling of crawling, bugs crawling underneath the skin. Severe cardiac arrest, seizures, and again for amphetamines as well, benzodiazepines. Benzodiazepines for amphetamines, benzodiazepine for cocaine. And for nicotine withdrawal, you use nicotine patch, gum, lozenges, or varenicline or bupropion. Okay, patient was start.
How do you differentiate? Like, I always get confused between atropine and stimulants, because when you're using atropine, the parasympathetic is getting blocked and the sympathetic is increasing. How do you differentiate it? I read it somewhere that even atropine can cause insect like trolleys of cocaine. So how do you differentiate it?
I think they will probably not use that as a on the exam day. Like they won't ever add cocaine the crawly thing on exam when it comes to atropine. Secondly, usually these patients might be those who present with suicidal attempt. Okay, suicide attempt, or more frequently they will test you on organophosphates. Whether organophosphate, the terrorist attack, typical scenario, or a farmer, exposed to pesticides. That's the kind of question they will ask. Atropine overdose, usually, it will usually present with a patient who is trying to commit suicide. A patient who is, taking cocaine is trying to have some good time, right? Is a young guy, college guy, and is trying to have some good time and ends up with all these symptoms and stuff. Most likely, most of these scenarios, the typical scenario will be a college student brought by his friends from a party where they mentioned that, okay, he was, he was fine, he was doing a little drinks, and now he has all of these things. And then you examine all of this, pupillary dilatation, diaphoresis, hallucinations. This is how usually they build the scenarios on the exam day. They don't really go into the typical exceptions on step 1. Okay, few percent of the people can have. Other than that, atropine what will atropine do to the heart rate? It will increase the heart rate, right? And what will it do to the blood pressure? That will also increase, right? Yeah, heart rate, blood pressure will probably increase. I'm trying to figure out something that.
I think the only thing is sweating. I think sweating will decrease it.
Yes, correct. So in atropine, yeah, there won't be any sweating. Patient will be dry. Yes, correct. Yeah, flushed skin, dry and flushed skin in organophosphates, atropine, and yeah, correct. Absolutely correct.
Other than that, nothing else, right? Just sweating.
Yeah, I think so. Bradykinesia study on fluphenazine for acute psychosis, and so tremor, partial instability, bradykinesia. These are what kind of symptoms are these?
Parkinson's.
Yes, and how do you treat it? So benztropine and metadine. Again, fluphenazine is high potency antipsychotic. Hypertensive ones are associated with extrapyramidal side effects. So Parkinson, benztropine, amantadine. These drugs are. They ask a lot of questions in the CK. I didn't get a lot of questions on the step 1, but in the CK, so many questions about these things, these side effects. Patient has MDD. Let me see what's the time right now, so that we can take a break when it's appropriate.
It's the break time.
Yeah, let's take a break. Let's be back, and then we'll try to speed up because a lot of things we are already covering along with the slides, previous slides. Okay, and there will be a lot of repetition of the stuff. Let's get back at 9:55, I think. Yeah. All right, everybody. See you guys soon. All right, everyone, can you guys hear me? Okay, I hope everybody's back. So this patient has a history of major depressive disorder, and you started him on a medication, presents to ER after 2 weeks, and he went to a wine tasting event, had fruits, salami, etc. Blood pressure is high. Which antidepressant was he taking?
An SSRI? It's a hypertensive crisis, but
Yeah. Can SSRI cause hypertensive crisis?
MAO.
Inhibitor.
So,
yeah,
MAO
with
inhibitors. So these foods, they have tyramine, which is usually broken down by
MAO.
yes,
MAO
MAO in the gut.
inhibitors, yeah.
Yes, and MAO, if MAO is not there, tyramine basically it replaces the neurotransmitters, and it causes their release into the synapse, and causing severe hypertension. The problem with psychiatric drugs is that they have so many different names, which are similar to so many others. For example, TCS, a lot of them imipramine, etc. And now you have tranylcypramine, all right? And phenelzine, isocarboxazide, selegiline. Same thing goes for all the classes. What is doxepin, for example? Doxepin is?
SSRI.
Doxepin is not SSRI, this is? TCA, right? So keep these variations in the names in mind, because otherwise, okay. Contraindicated with the SSRIs, TCA, St. George Wort, mepridine, dexamethasone. This is because to avoid Stratton syndrome, so linezolid, mepridine. There are other drugs as well. What drug taken for migraine can cause Stratton syndrome along with SSRIs, for example, or TCAs? So
Sumatriptan?
yes, the triptan drugs, they are also agonists, certain agonists. So the entire list is very high yield. Okay, St. John's Wort. They may tell you the patient started an SSRI, later on tries some over-the-counter herbal supplements for his depression, and now presents with all the symptoms, all the things of the certain syndrome. Okay, patient has hallucinations, anxious and flat affect, and delusions for 8 months. Diagnosis will be disorganized speech, all the positive and negative symptoms. This is
Schizophrenia.
so what do you find on the brain? Let's say MRI in schizophrenia patient. What can you find? So yeah, ventromegaly can be there on the brain. Okay, there's a patient who has presents to your clinic, and then he wants to be seen at the first priority and says he's far more important than others, and he has history of multiple sexual partners, excessive drinking. This diagnosis is which personality disorder? So this is narcissistic, all right? Narcissistic, some of their presentation. So they are attention seeking, just like histrionic as well, but that attention comes from having a extreme self-importance, grandiosity, sense of entitlement. So they might require excessive admiration. And on the other hand, so narcissistic, you may think of them as more like bureaucrats and military officers in the developing world. And histrionic are usually more about the artists, some of the traits like dramatic speech, emotional expression, shallow and labile emotions, sexually provocative, attention seeking. So you can associate these different personalities to individuals, certain individuals, and you would be probably be good at remembering it. And borderline, talk about that. So the mood, the mood swings in borderline, they are basically, they last for hours instead of days. So they might be excessively happy or excessively sad, but you won't consider it a bipolar until you have the entire 1 week of typical symptoms requiring hospitalization in type 1 bipolar disorder, for example. So some of the things can be related to some, and splitting, impulsivity, self-mutilation. Often they will give you a patient, young female patient with the, on examination you will have the wrist, cut marks on the wrist, and had a short-lived relationship, maybe started a new relationship for 7 days and broke up, and now thinks life is over. Okay, the person was her soulmate and everything like that. Treatment is dialectical behavioral therapy. Some of these therapies, of course, you have CBT everywhere, but some of them, like dialectical behavior therapy, again, I don't know what exactly is that, but keep these exceptions in mind. Yeah, exceptions can be tested. So they may give you SSRI and psychotherapy, so you will go for psychotherapy kind of thing, dialectical behavioral therapy. And of course, all these personality disorders, they're treated with psychotherapies instead of medications. And antisocial, talk about that. Patient must have history of conduct disorder before age 15. What's the first line treatment for schizophrenia? This is patient has schizophrenia. 1 year history of all of these symptoms. So is it typical antipsychotic? Psychotics for first line as a first line treatment? Schizophrenia, what do you give as a first line treatment? Is it typical antipsychotics? So it's actually atypical antipsychotics for the first line. Quetiapine, risperidone. So if usually first generation antipsychotics, especially haloperidol, can be used in acute setting, acute psychosis. But usually for long term, the second generation ones are preferred. Okay, little boy, 4-year-old, his grandfather died recently, and he's fine, everything is fine. He claims that he spoke or saw his grandfather around. What's the diagnosis? Is it psychosis?
Grief.
So this is normal grief. Okay. The auditory or visual hallucinations can occur in the context of normal bereavement, hearing the disease speaking, for example. Okay, keep that in mind. One important thing while solving the psychiatric questions on the exam is related to functional impairment. Usually psychiatric illnesses cause functional impairment. If the patient is fine when it comes to the psychosocial functioning and work and everything, you might think of something else instead of so functional impairment. So for grief, if the patient is fine, doing his things, he loves everything, you won't probably diagnose it as with the severe adjustment disorder. Or so complex bereavement, if it's more than 12 months. Severe grief interferes with functioning for, let's say, this man had his wife dead for maybe 16 months, and he refuses to go to work or go out and all of that, that would be persistent complex bereavement. Patient has 9-year-old girl has bedwetting. In the class, she's making inappropriate jokes, and you see pink fleshy papules on vulva. Most likely this is
Regression.
well, not depression. So
Regression.
And
this is actually sexual abuse.
Mhm.
Inappropriate jokes or knowledge of sexual knowledge and sexual abuse, and you have to interview her alone, and then if the suspicion is correct, then you will have to involve social workers. So sexual abuse, children often exhibit sexual knowledge or behavior incongruent with their age. There is this question in CK in which this 4-year-old baby was simulating oral intercourse with a doll. Okay, and that was basically the clue that there must be something wrong. So knowledge, excessive knowledge, sexual knowledge, behavior. Yeah, there could be trauma, but most often there are no physical signs. The most common age is 9 to 12 years old, the peak incidence of sexual abuse. And physical abuse, you have to differentiate it from osteogenesis imperfecta. That's the favorite question, examiner question on the exam day. That is osteogenesis imperfecta with multiple healing fractures. But then you'll have other symptoms of osteogenesis imperfecta as well. You know, hearing loss, blue sclera, teeth, you know, all of that. And in physical abuse, it can be, so most of often either it's a young mother, you know, a very young mother, where you know, and the baby, usually the baby is less than 1 year old, the most common. So maybe 6-month-old baby with the proper circumscribed burn wound, or a patient with if a baby with injuries and the mother claims, you know, the baby is 1 month old and mother claims that the baby rolled off bed, and while the baby cannot roll at age 1 month or 2 months. So that would be these kind of clues. Sometimes it's the stepfather, or you know, who is the, and then more things that might be give you clue about physical abuse, or you know, generally abuse in a clinic setting is, for example, baby is brought late to the emergency department. You know, let's say the baby, mother claims the baby had burned 10 days back, and you know, once the infection has occurred and necrosis, and then the baby bring the baby to the hospital. They you know, they don't, if the parents do not allow interviewing the child alone, you know, there's a 5-year-old child and you are suspecting abuse, and you want to talk to the baby alone, you are like, you know, you want respectfully ask the patient, request the parents to step out, and they refuse to do so. Okay, and they refuse treatment, they refuse these are kind of things are clues to abuse. The retinal hemorrhages in a baby, you know, this is pathognomonic for abuse. They cannot occur except with vigorous shaking. A baby cannot have fallen and gotten retinal hemorrhages. All right, so shaking, excessive shaking, and then these patients basically subdural hematomas, they shaken baby syndrome, they will basically develop sort of coma, poor feeding, and this is the kind of their presentation on in the clinic. And yeah, they may delay treatment, provide explanation inconsistent with the development stage or pattern injury. If there is a well circumscribed burn, you know, from the feet all the way up to the thighs, and the mother claims the baby accidentally fell into the warm water, that wouldn't be the case. You know, in that case, the burn would be more generalized, and then there would be splashes and all that. But if there is well circumcised, means the mother was probably holding the baby and putting her in boiling sort of or hot, extremely hot water, you know, or cigarette burn marks and all of these findings. So similarly, STIs, you know, a scenario with a 3-year-old baby girl brought to the hospital with the vaginal itching or dysuria, and you take a urine sample or sample of the discharge, and it grows Neisseria later on, okay, or chlamydia, that is sexual abuse. Okay, and emotional abuse, again, withholding affection, you know, again, well, that would be child neglect actually. In emotional abuse, it's an act of commission more likely, and distance themselves from caregivers and other children, emotionally bile in older children, and babies may over affectionate with less familiar adults, aggressive toward children and animals, are unusually anxious. Vague somatic symptoms, you know, like abdominal pain or and childhood abuse history is related to developing psychiatric illnesses in while being an adult. Okay, so this is 5-year-old girl does not interact with peers or listen to teachers, and repeatedly draws circles, avoids eye contact. Diagnosis areas.
Autism.
Autism.
Yes, autism spectrum disorder. There would not be any neurological for exam findings except, you know, repetitive movements, doing the same thing over and again, does not socially communicate. So it's a social and communication deficits, ritualized repetitive behaviors. So mood swings, difficulty sleeping, spent all savings, 1 to 2 hours of sleeping only, and irritability, labile effects. This is manic episode, and the treatment is
Lithium.
Lithium.
yes. So this is bipolar disorder type 1, not type 2. So if it was type 2, then you would see maybe, you know,
Maybe
so there would be
different
history of depression, you know, and
Hmm.
the episode would be mild. Basically, she is more active. For the past 4 days, she's sleeping only 4 to 5 hours, is finishing more assignments, you know, and that would be more like a hypomanic episode, as opposed to, you know, spending all the savings and requiring hospitalization and these pressures. Okay. Normal BMI, calluses on knuckles of the hand, and worry about body weight. BMI is not the diagnosis is.
bulimia.
So this is bulimia because BMI is down. Let's say this patient does not have. So the patient comes to you, has BMI is, let's say, 26, and says that she cannot withhold herself from food, and occasionally has episodes where she eats a lot of food. What's the diagnosis?
Still bulimia.
So if there is no compensatory behavior, it would be just binge eating disorder. So if there's binge eating without any purging behavior, that would be binge eating, in which and in fact a lot of people do that. We have here free meetings over here, like not free meetings, basically meetings and seminars going on for other purpose, some other purpose, and so we have so many medical students who would randomly show up and then do the binge eating thing. You know, a lot of binge eating. Some will bring food from there to the hostel. I mean, we used to do that back then as well. But there is no purging behavior here. Or Muslims, when they're fasting, interestingly, most of them by the end of Ramadan they gain weight. You know, you would expect that by fasting for 1 month they will reduce, because the moment they during the evening, the breaking their fast, and then in the morning before the sari, they will eat maybe twice or thrice of the normal meal size. And yeah, anyway, so binge eating disorder, SSRIs, psychotherapy, and lisdexamfetamine. So stimulant being used here. You don't see any stimulant being used in bulimia or anorexia. And these patients may have bulimia, may have dental erosion, Malraux syndrome, you know, excessive, you know, the linear tears at the gastrointestinal junction, again differentiated from Boerhaave, where there will be pneumoniasinum and crepitus and toxic patient. And because vomiting, it is high, it has hydrogen ions, chloride, and it's a lot of potassium ions. So there will be low hypokalemia, hypochloremia, and alkalosis, so metabolic alkalosis. On the other hand, if it's a patient who, bulimia nervosa patient who is using, let's say, laxatives to lose weight, then you will see metabolic acidosis because you're losing primarily bicarbonate, right? Or sometimes these patients may actually be using diuretics to lose weight by getting dehydrated, and they're thinking, okay, they're losing body weight. And in that case, depending on the diuretic being used, let's say furosemide, then you can have the abnormalities according to that. So it's not always going to be metabolic alkalosis. It is going to be dependent on the form of compensatory behavior that the patient is displaying. And parotid gland swelling may be there, dental enamel erosion secondary to gastric acid, and knuckles because they are inducing the vomiting, and the dorsal hair and calluses, Russell sign, they might the hands, basically the knuckles might come in touch with the upper teeth, and that's where they might develop these calluses. And another eating disorder is pica, common in pregnancy and in malnourished children, and associated with anemia, etc. They will have so if it's a developing world baby, a child, 5-year-old with pica, most likely iron deficiency anemia, secondary to either lower iron consumption, or maybe it could be due to worms and xylostoma, for example, duodenally, hookworms, Nicteria americanus, all of those. So that could result in iron deficiency anemia, and iron deficiency anemia causing causing them to eat eye stud, hairpin chips. In pregnancy, there might be, for example, craving for ice, eating ice over and over and over again. So that would be pica. And you have to do the nutritional rehabilitation psychotherapy is the first line, and second line is SSRIs. So all of these eating disorders, you can see psychotherapy being over there. So treatment, psychotherapy, 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 and psychotherapy. Psychotherapy is a part of all the treatment. SSRIs can use in pica, binge eating disorder, and bulimia nervosa, but not in anorexia nervosa. And anorexia nervosa using olanzapine, because olanzapine can cause weight gain, right? Increase appetite and weight gain. So that's one of the ways to treat these patients. We talk about this binge eating and purging type, restricting type. So in purging type, they may, it will be similar to bulimia nervosa patient, laxative, diuretic, or vomiting. Okay, and restricting type, they will stop eating. All right, that's it. And in refeeding syndrome, basically any patient who is severely malnourished, when you give them, when you rehabilitate them, that results in excessive insulin release. Okay, and that insulin causes, for example, hypokalemia. Of course, we know that insulin increases the activity of sodium potassium pump, and phosphate is consumed within the cells for ATP production. Okay, and magnesium is taken as well. So severe hypokalemia can lead to cardiac complications, and arrhythmias, etc. They can be seizures. Again, seizures are related to the electrolyte disturbances and rhabdomyolysis. All of these things can occur. Yeah, so that is refeeding syndrome. Six weeks. Symptoms of psychotic symptoms for 6 weeks. Diagnosis is schizophreniform, correct. Okay, suicide attempts, boyfriend extremely selfish, broken up multiple times, unstable relationships, outbursts of physical aggression, mood swings that last few hours. Diagnosis is borderline, and they will use which eco defense they'll use splitting, right? Talk about this. Patient with diaphoresis, pupillary dilatation, hypertension, and hyponatremia. We talked about this. This is MDMA abuse. All right. And basically, these patients have a lot. It induces release of ADH. A lot of ADH is released, and also these patients, they drink a lot of water when they are on MDMA. So they will drink a lot of water. A lot of ADH will be released. Inappropriate levels of ADH. Both will contribute to developing hyponatremia in these patients. So this is MDMA, and that's where you have hyponatremia. All right. Hyponatremia, certain syndrome, we talked about that as well earlier. Hyperthermia, tachycardia, hypertension, euphoria, hyperactivity, increased thirst. All right. So thirst, so they will drink a lot of water, and ADH will be released, more ADH will be released, so that will result in hyponatremia. Okay. PCP is again a common question in the exam scenario. I haven't seen really a lot of MMDM questions, but I've seen the cannabis questions, phencyclidine, cannabis, typical, conjunctival ejection. This is there, and slow time, pain judgment. Of course, cannabis is very common, and college students, etc. And appetite is increased, so they eat a lot. So when I was traveling in US, there was this guy who was traveling with me in the bus, and he had conjunctival injection. He told me he's traveling from Boston, and he has been traveling for a few days. And it was basically his birthday party. And the way I diagnosed him with the cannabis use was when he asked me to. He told me he was very hungry, and I had some food with me, and he asked me for food, and I gave it to him. Then he asked for more and more and more until I was out of food, and then I realized this patient is on something. This guy is on something, and he was on most likely cannabis. He was having cannabis for his birthday. Anyway, so phencyclidine, these patients, the most common of death in patients with phencyclidine overdoses or phencyclidine abuses. What causes death in these patients? So it's not the phencyclidine itself or any, it's basically the violence that results from it. They may end up acting violently and end up getting killed. Okay. So violence, nystagmus, impulsivity, agitation, meiosis, tachycardia, and they won't remember it later on anything once they are stabilized. Hypertension, psychosis. So you can see meiosis is over here. You will see mydriasis over here. LSD, a friend of us, he overdosed on LSD for the exams, and he had all of these things. So mydriasis, meiosis over here, and conjunctival injection. So the ocular manifestations, they can act as clue somehow.
So can you go the previous? So research acid is the other name?
Yes, diethylamide, lysergic acid diethylamide. LSD, it's perceptual distortion is the primary presentation of these patients. Mydriasis and perceptual distortion. They can see various, I think, colors and hear weird things. So their visual and auditory experience gets affected. Okay, they look at something and would find colors around it. and they would listen to something and it will sound like something else. So it will be distorted. It's a weird experience, I think, if the people who
So
have it. Depersonalization is
yes. How they describe
they don't
this?
feel. So depersonalization is when you feel yourself out of your body. So depersonalization and derealization, these are two things.
Oh, yes.
Depersonalization, you have out of the body experience, right? And in derealization, you find your surroundings to be unreal. They don't feel like the real world. Okay. All right. Let's move to the next. A patient is in an abusive relationship and does not leave her husband, and thinks has very low self-esteem, thinks nobody will hire her because she doesn't have any skills, and she's depending on the husband for bills and everything, and husband takes care of every single thing. This diagnosis is, which personality disorder is this? So this is a typical dependent personality disorder in which these patients have low self-esteem, low self-confidence, and they are excessively clingy, excessively dependent on others for the similar, simple little things, and they often end up in abusive relationships, which they won't quit because they think they won't survive without that abuser with whom they are in relationship. We talk about OCPD when we're talking about OCD, that this is consistent with their own beliefs and attitudes. They believe that what they're doing, the perfectionism, what they're doing is what is the right way to do things. Okay. They have trouble with working in teams. The obsessive compulsive personality disorder patients, they cannot work in teams because they believe everybody else is not doing things the right way. They want to check everybody else's work. They want to see what is this guy doing, that guy doing, and they want to correct what they're doing. Okay. So it's very difficult for them to work in teams. They make long schedule. They wake up in the morning, spend 2 to 3 hours making the schedule for the day. Okay. They have to submit a presentation and they will change it and cut it over and over again, and spend hours and hours a day, and they still think that's the right way to do it. That's the difference between obsessive compulsive personality disorder and OCD. And the way these patients might show up in your clinic is the way they might show up in clinic is for something else. They are like, I'm having headaches secondary to maybe poor sleep, and poor sleep may be secondary to excessively working with lists and everything. And avoidant personality disorder, they have to be differentiated from what? Schizoid personality disorder. So avoidant personality disorder patients, they avoid social situations, but the reason is they feel inadequate and they are sensitive to rejection and criticism. They don't, and while they want relationships with others. So a patient comes to you and with her mother, and mother says she has no friends, and you ask the patient, and the patient says, who would like to be friend with an ugly person like me? This patient has avoidant or schizoid? Patient has no friends and tells you, who would like to be friend with an ugly person like me? This is this schizoid, or is this avoidant? This is avoidant, right? The statement that who would like to be a friend with an ugly person, it depicts inadequacy, it depicts low self-esteem, it depicts the fact that people won't want to be friends with her. Instead of a patient with schizoid, if the schizoid patient brought to you, the same patient will tell you, no, I don't want to be in a relationship with anyone. I don't want to meet anyone. I think I'm better off on my own. I don't want to work in a, these people will be, the best place for them will be working in a watchtower, lighthouse, in a lighthouse. So lighthouse is located in certain islands for the past several centuries, and all they do, the guy who lives there with the family or alone, is the entire thing that person has to do is to get up, light the lighthouse, and live the rest of the life on that island alone. All right, this is the kind of job they like. Okay.
Or they can become surgeons.
All right. Well, surgery requires a lot of social interactions. But yeah, surgeons hate clinics. Any surgeon, they feel the lowest in the clinics and they feel the most jubilant and manic in the OR. So they really don't want to do clinics and rounds. In fact, they don't do rounds at all. They do clinics and OR. Okay. Elderly guy with sleep onset insomnia. All right, like he lies in bed for an hour or 2 hours before falling asleep. What drug would you prescribe him? Would you give him short acting benzodiazepine?
What is sleep onset insomnia? Like sleep is happening and then there's insomnia.
So this is, so what drug would you give to this patient? So you won't use benzodiazepine. The point to take away here is you don't use benzodiazepines in elderly, right? Risk of falls. There's a list of medications not to be used in elderly, including PPIs, alpha-1 antagonists, causing orthostatic hypotension and falls and stuff. Benzodiazepines again, sedation and falls. Antihistamines. A list of the Beer criteria, I think. So instead, you will give non-benzodiazepines hypnotics. Again, zolpidem. Zolpidem is a favorite medication of USMLE exam takers. People take it before the exam night. Well, I didn't take it, but I know people who take it. But of course, if you're trying to use a medication before the exam night, make sure you actually have used it earlier. Do not try a new medication on the exam day. Okay.
What you say?
So non-benzodiazepines hypnotics, which act on the BZ1 subtype of GABA receptor, but they're not benzodiazepines per se. Okay. So they can be used for insomnia. Okay. And they have short duration, decreased dependency risk as opposed to benzodiazepine, right? People end up becoming addict to benzodiazepines. And yeah, Suroxrent. So orexin is, hypocretin is something that keeps you awake, and it's low in what? Narcolepsy, right? Narcolepsy patients have low levels of hypocretin orexin because it keeps you awake, and antagonist against this hormone will cause you to sleep. So this is contraindicated in narcolepsy and not recommended in liver disease because I think their metabolism occurs in the liver and limited risk of dependency. Ramelteon, I think, is the safest one out there. It's melatonin receptor agonist. It's used by mostly people. So for jet lag, this is sort of first line for just jet lag patients are traveling frequently. Essentially, it will work like your endogenous melatonin, and it will help with the jet lag. It will initiate the sleep onset right away. Melatonin in human body is dependent on, its release is dependent on what? On circadian rhythm. Okay, it is released in a circadian rhythm way. However, it can be inhibited by blue light, for example. So excessive exposure to blue light may cause poor sleep, difficult onset of sleep, but its release is related to your sleep schedule, when you sleep, when you wake up. The residents who are sleeping 5 hours a day for several years, I think, and eventually the melatonin the release of melatonin goes down because there is no particular sleep cycle. There is no circadian rhythm. All right, tough years coming ahead for major depressive disorder episode. Patient with major depressive disorder, and now comes to you with the QRS prolongation, hypotension, pupils, etc. Which drug is he taking?
TCA.
Yes, TCA is associated with QRS prolongation. And how you treat it?
Sodium bicarb.
Sodium bicarbonate. What does sodium bicarbonate do? It's given for, is it given for removal of the drug from the body? So it's cardioprotective. It's to prevent arrhythmias, because there will be sodium channel inhibition, and by having excessive sodium around, you will displace the TCAs from the sodium channel, and so sodium carbonate to avoid arrhythmias. Back then, I was, in the initial first year medical student, I was watching an autopsy on the YouTube, and they started it with, okay, this young women had, we are suspecting overdose of amitriptyline. That's what they mentioned. Okay, back then, and that's how I remembered. Okay, this can cause cardiac and all that. So again, major depressive disorder, not first line. Okay, it's more commonly used for nocturnal aneurysm, OCD, but in lower doses. Okay, so I mean, what's the point of treating for nocturnal aneurysm if the baby the boy develops all all of this? So it's used in low doses over there. Imipramine. OCD again, second line. First line is SSRIs, right? And migraine prophylaxis. Other drugs for migraine prophylaxis include, for example, beta blockers, right? Chronic neuropathic pain. Yeah. So that's what I was talking about. Doxepin is TCA. Amoxicillin, doxepin, clomipramine, disipramine, imipramine, nortriptyline, amitriptyline. Paroxetine given to a depressive patient. What is the greatest risk for this patient?
Suicidal thoughts.
Yeah, so initially they can have subtle thoughts, but like which side effect is most common in patients on SSRIs?
Sexual dysfunction.
Sexual dysfunction. Correct. So don't pick serotonin syndrome. That's because that's going to be rare. This patient is at, again, South Asians over here will not probably think of it as a side effect, but it matters a lot to the people in the Western world. So SSRIs, again, serotonin syndrome, GI distress, SIADH, decreased libido, anorgasm. Interestingly, this is a treatment for what sexual disorder? Premature ejaculation. Premature ejaculation is defined as ejaculation in less than 1 minute of intercourse, initiating the intercourse. So these patients can be given as paroxetine, for example, to delay their orgasm, and so that they don't. Okay, and don't use it if the patient has history of any manic episode. So there's so many of these. We talk about the binge eating, bulimia, OCD, panic disorder, CBT, and SSRIs. These are the bread and butter of psychiatrists. Whatever either of these is going to work. Boy's patient, parents have divorced, and now he has starting using drugs, skipping classes, aggressive behavior, bullying, which ego defense. And when you ask him, he says everything is fine. I'm not doing anything wrong. This patient has what ego defense is he using? So this is acting out. Okay, this is how he's coping with the stress. and the conflict. He is using these actions to avoid that. Again, this is subconscious. The patient might actually deny doing that out of the stress. Guy, this is employee who is on probation by the boss for poor performance, and he goes back to his home. His wife says that she's supportive of him, and later on he accuses his wife of being a failure. Which ego defense is this patient of believing he's a failure? This projection. So he thinks he's a failure probably, and he's projecting that on the wife, that accusing the wife of thinking that he's a failure.
What is the different repression and suppression?
Repression, the patients involuntarily hold an idea or feeling from conscious awareness. They don't even know it ever happened. Okay, patient may have a history of sexual abuse, and the patient does not remember it at all. Her mind has removed that from her consciousness. It has gone into her subconscious. She cannot recall it despite thinking. In suppression is a mature defense. The patient is aware, but the patient voluntarily withholds or suppresses the thoughts related to whatever is causing him anxiety. For example, if a student has exam, 10 days from now, he thinks, if he suppresses that thought and focuses on the immediate goals, the work, what's important for that day. So I think that's important on USMLE as well. Instead of thinking about worrying about the exam day all the time, if one sticks to the daily routine and ensuring that you're doing something every day and you're reaching your daily goals, that's better than thinking about exam all day, 3 months before the exam, 2 months before the exam, even 2 weeks. Similarly, suppression is people suppress their anger. Maybe some people suppress their sexual thoughts. So suppression is a behavior in which voluntarily they are withholding. Bulimia nervosa, what would you see in vomiting? Which acid-base disturbance? So we talked about that earlier. So hypokalemia, hypocaloremia, and metabolic alkalosis. If it was diarrhea, that will be metabolic acidosis. Again, hypokalemia as well. So diarrhea and vomiting both will cause hypokalemia, but here you will have metabolic acidosis in diarrhea. Okay, so diarrhea, what will happen to chloride levels in the blood? Will they go down? Blood chloride levels in diarrhea will actually go up. Why? Because it's non-anion gap metabolic acidosis. You're losing bicarbonate, but then the body is compensating for that by releasing chloride into the bloodstream. Cells intracellular chloride is these. Okay. Soldier returned from Iraq now has difficulty sleeping, nightmares, guilt for more than 6 weeks. Diagnosis. So this for 6 weeks. This is. Suppose PTSD. What if it was for 3 weeks? It would be acute stress disorder. That would be acute stress disorder, right? For 3 weeks, 2 weeks, and the diagnosis would be PTSD in this case, and the treatment would be CBT, and you can use SSRIs, and prazosin can reduce nightmares, but prazosin will not be used alone. If one of the options include only prazosin, that would not be the answer, because it's used in in conjunction with the CBT or SSRI. Start with that acute stress disorder, 3 days to 1 month. Adjustment disorder. Now they don't meet criteria of another psychiatric illness, which is basically they might have anxiety symptoms, they might have depressive symptoms, but they won't be enough to meet the criteria for, either panic disorder or generalized anxiety disorder or major depressive disorder. Okay, so they will have some symptoms. They, just a disorder patient might have low mood and low concentration. That's it. Everything else is fine. And so if they are there for more than 6 months, then they have to be evaluated for major depressive disorder or persistent depressive disorder, or so they can have both anxiety and depressive symptoms. So that keep that in mind as well. Okay, patient has been going to multiple physicians, and there is nothing wrong with her. She complains of back pain and dyspnea. Diagnosis will be
36 gain, 36.
Hypochondriac.
Somatic.
This is somatic symptom disorder. And what do you do for this patient? Yeah, so you should schedule regular follow-up visits. What if this patient goes to multiple physician, thinks she has breast cancer, all the tests have been negative? What's the diagnosis then?
Can you repeat again, please?
Yeah, so if this patient has been visiting physicians and requesting workup, thinking she has breast cancer, what would be the diagnosis in that patient? And all the workup has failed to find any clue of
Illness, anxiety.
that. Was the illness anxiety disorder. What I'm trying to differentiate over here is between somatic symptom disorder and illness anxiety disorder. Illness anxiety disorder patients will not have any symptoms. This patient has lower back pain and dyspnea. Okay, there might be another patient who might have, who has multiple increased urinary frequency, who might have, all those.
Slowly, please. What can two differences? What is the two differences? Can you show it again?
Yes. So somatic symptom disorder versus illness anxiety disorder. So they both of them may present with recurrent visits to physicians and requesting workup and diagnosis and all. The difference will be there is minimal to no somatic symptoms over here. Patient thinks probably she has cancer, she has Alzheimer, or he has some other disease. Okay, and all the tests are normal. On the other hand, in somatic symptoms, patient actually has a complaint. There is abdominal pain, there is fatigue, there is dyspnea, there is back pain, and then they go to the physicians over and over again. Workup is normal. Okay, so that's the difference between somatic symptom disorder and illness anxiety disorder. And convergent disorder is an acute onset of loss of function. So can be sensory or motor, blindness, paralysis, mutism, and often this in the exam the scenario will be a patient who had a recent heard bad news or was fired from the job, mostly female patients, and they are brought to the clinic and with the complaints of inability to move the right hand, for example, and you ask them to move the right hand, they're unable to do so, they don't have any power over there. But when you do reflexes are normal. Okay, it means that's a conversion disorder. Similarly, problem with moving the left leg, reflexes are normal. Okay, and they are usually indifferent towards symptoms, as opposed to somatic symptom disorder and illness anxiety disorder, there where they're frequently visiting physicians and stuff. They might actually be brought by a relative. Okay, the spouse or the son or the daughter or someone who is bringing them. It's more common in females, adolescents, and young adults. And unexplained loss of sensory or motor function, blindness, mutism. No. So blindness, suddenly they cannot see anything. You do fundoscopy, everything is fine, right? And the workup for stroke is fine. There is no problem with the carotids, with the heart, everything is fine. That's how you will differentiate between these three things. So it's not important to know every single thing about every single disorder. What's important is to actually be able to differentiate the differentiating point between different disorders. That's what's useful for the exam day. Okay, there is a boy who's brought by the mother. There's hypoglycemia. You manage the baby overnight. There's another episode of hypoglycemia, and you see the serum insulin levels are high, C peptide is low. Diagnosis is
Exogenous insulin taken.
yeah. And what's actually happening over here? This is factitious disorder imposed on another. The mother is injecting the baby with insulin, okay, to receive the medical attention on behalf of the child. Similarly, let's suppose a baby is brought by the mother to the clinic with the recurrent episodes of UTIs. You know, it's this child, 4-year-old baby girl, recurrent episodes of UTIs, and you end up finding that the mother has been injecting feces into her urethra, right? And that's what is giving the baby, the child, recurrent UTIs. So basically, this is factitious disorder imposed on another, and this is actually a form of child abuse, okay, in which the mother is using the child as a proxy to receive that, you know, medical attention, and is basically causing harm to the baby. So imposed on self. So this is how you differentiate factitious disorder from the malingering. Factitious disorder patient is unwilling to go invasive procedures. Okay, malingering patient, the soon you tell him that you need urgent surgery, he will run away from the clinic, right? In fact, some of the physicians, they have used this tool to actually differentiate the malingering from factitious disorder. That the guy shows up to the clinic, you know, wants sick leave or wants to stay overnight in the hospital, and the physician, and has been doing that for multiple times, and the physician suspects that this patient might actually have malingering. What they'll do is that you have a condition which requires urgent removal of your left urgent removal of your left kidney and your left testicle, and if the guy, you know, runs away right away from the clinic, it might be have to do with malingering. Okay. And the factitious disorder imposed on another has to be differentiated. Vulnerable child syndrome. Vulnerable child syndrome, baby is being brought to the clinic again and again by the parents, but the reason is they're excessively concerned about the baby. The baby probably had an episode of life-threatening illness, and now any symptom they see in the baby, they bring the child to the hospital. Okay, baby, let's say baby has meningitis. Okay, life-threatening meningitis, and now whenever the baby has a headache, the parents rush the baby to the ER, okay, and want basically all the workup done, lumbar puncture done, everything done. So in this case, the way it's different from factitious disorder imposed on another is, in the factitious disorder imposed on another, the symptoms are created by the fabricated or created by the caregiver. They are doing something to cause the illness. In vulnerable child syndrome, the baby has a symptom due to, you know, maybe have some flu or something, little bit of abdominal pain, and the parents rush the baby to the ER thinking, okay, this is some other life-threatening disease. Okay. So malingering symptoms are intentional, motivation is intentional. You know, they know they're doing this to get a secondary gain, which may have to do with you know, any benefits or anything. Factitious disorder, they're creating their symptoms themselves, but the motivation is unconscious. By unconscious motivation, they don't know exactly why are they doing this. They know they're doing this themselves, you know, creating the symptoms and stuff, but there is no primary there is no secondary gain involved. Like if they are asked, so there is not, they don't have, they're not doing this to get, you know, employment benefits or disability benefits or anything like that. It's basically just to receive patient care. So this is the primary gain, to receive medical attention, that's all it is. And their motivation is unconscious. Okay, they would disagree to the fact, if you tell them you're doing this for medical attention, they will disagree to that. They're like, no, I'm not doing this for medical attention. Okay, because it's unconscious. And in somatic symptom disorders, symptoms are unconscious and motivation is unconscious. The backache the patient is feeling, the patient is probably actually feeling that backache, okay? And but there's and the patient doesn't know why, you know, why the motivation as well. It's not for, you know, for a specific gain. Factitious patients, they will be doing whatever they're doing. They're creating their symptoms themselves, but they're doing it without any typical personal gain, secondary gain, basically. So patient develops anxiety, agitation, tremor, nausea 2 days after surgery. What's the most likely cause in the clinic? If this is your only question.
Alcohol withdrawal.
Alcohol withdrawal.
Delirium tremens. Yeah.
Yeah, delirium tremens. What's the treatment for delirium tremens?
Chlordiazepoxide.
Chlordiazepoxide is metabolized by liver. This patient has alcoholic liver disease. So for this patient, you will use the ones that are not metabolized by liver, which is lorazepam, oxazepam, and temazepam.
Okay.
Yeah. Okay. So keep these types of clues in mind. Okay, you don't want to give them something that is. So this is a patient. Lorazepam, oxazepam, and temazepam can be used for those with liver disease. Okay, because they have minimal first pass metabolism. Similarly, the short-acting ones, alprazolam, prazolam, oxazepam, midazolam, they won't cause, for example, next day sleepiness. But the problem with them is their effect wanes quickly, and that's why they have a higher addictive potential. The guy wants it again because if there was an effect for some time, then quickly wanes. And the other problem is you can't use it for example, delirium tremens, because of course, unless you have liver disease, because the effect will wane, and then the patient symptoms might recur. This also applies to the fact that naloxone has to be given repeatedly sometimes for opioid overdose, because patient might suddenly wake up with if they're giving naloxone, but if they overdose on a long-acting opioid, they will redevelop, you know, meiosis and symptoms of overdose, like respiratory depression, etc. Flumazenil is competitive antagonist at GABA benzodiazepine receptors, but usually don't use it. Flumazenil is not usually used. Usually these patients are just given supportive treatment until they are fine, because flumazenil can cause seizures. Secondary, another point over here is if someone who is taking excessive benzodiazepines suddenly stops taking them, can also develop seizures. So withdrawal from benzodiazepines can cause seizures, as well as flumazenil can precipitate withdrawal as well, right? Because you're going to inhibit GABA receptors. So usually in clinical setting, because they don't have respiratory depression, except if they are also taking alcohol, okay? So if a patient presents with respiratory depression who was on benzodiazepines, it's likely that it's not just benzodiazepines. He probably is taking alcohol. So he took a lot of alcohol and benzodiazepines, that's why he developed respiratory depression. So treat overdose with flumazenil can precipitate seizures by causing acute benzodiazepine withdrawal. Probably you will only use flumazenil if there's severe respiratory depression, maybe, you know, otherwise. So if you see a scenario in the exam where the patient's respiratory rate is maybe like 7 or 8, don't think of benzodiazepine, rather this is most likely opioids or barbiturates. There's a 7-year-old boy who misses school by complaining of abdominal pain, wants to sleep in parents' room, and when we're sitting close to the mother in the examination, on the examination table, when mother wants to take a call outside, he starts crying. Diagnosis is suppression anxiety disorder, because 7-year-old boy should not have suppression anxiety disorder, right? It's normal for up to age 3 or 4, but not 7-year-old. So may lead to factitious physical complaints of avoid school, abdominal pain and stuff like that. Patient may complain of abdominal pain, skip school, and then you see him running around and playing. So CBT, play therapy, family therapy, more than 4 weeks at least. Specific learning disorder, you compare it with intellectual disability. Specific learning disorder has to do with only one typical skill. For example, either reading, unable to read, everything is fine. Other unable to write, everything else is fine. Unable to understand mathematics, everything else is fine. So these patients, if you take out that part from the IQ test, let's say the written part from the IQ test, it's only developed, and the patient has a problem with writing, the patient will have normal IQ. Okay, so the general functioning intelligence are normal. I have actually a friend whose brother has specific learning disorder. He's unable to understand the written text. Okay, he's otherwise he's fine, he understands everything, talks, nothing else is wrong. So they have to provide academic support, counseling, extracurricular activities, and maybe they might try to choose a career where they don't have to, it's not involved with writing or Tourette syndrome. We talk about that. So they have to have both work motor and vocalics for at least 1 year, and psychoeducation, behavioral therapy, and for intractable one you can use antipsychotics, alpha 2 agonist, tetrabenazine. Patient in a homeless shelter presents with sharp chest pain leading to the neck. Everything is normal. When you just want to discharge him, he complains he has numbness in feet. Next day suddenly leaves the hospital. This patient has, he is malingering basically. He needed to spend the night in the hospital. All right, he want to admit it. So he complained of the chest pain, and everything else is normal. The examination, etc. And then when you try to discharge him, he says, no, I have severe numbness in my feet. I need admission. Next day, without telling anybody, he suddenly leaves the hospital. So he just needed to spend the night in the hospital. Was there for a sleepover. So
what was the diagnosis?
malingering.
Malingering. Yes.
This patient just wants a sleepover in the hospital.
Okay.
Okay. Patient sadness for 4 years. Never had more than 1 month of 1 more month of symptom-free period, and all the symptoms he has is sleeping, difficulty concentrating, sadness. This is diagnosis is
Dysthymia.
So yeah, persistent depressive disorder. These terms like dysthymia, hypochondriasis, these are from DSM-4, which was in use from something like 1970s up till 2000, I think 14 or 15. And then now we have DSM-5, in which they have replaced those terms, for example, hypochondriasis with illness anxiety disorder. In fact, in DSM-5, they have removed the clusters. They had clustered, the personality disorder into 3 clusters. They have removed the clusters. There have been some changes in the current DSM-5 psychiatric criteria. So, similarly, there is no postpartum depression. They call it major depressive disorder with peripartum onset. Similarly, no dysthymia or other persistent depressive disorder in the DSM-5. Basically, they're making all the words longer and longer. There's a good talk by on the fact that with the back then used to call people cripple, who couldn't maybe walk. Then it became disabled, then differently abled, and then patient with special abilities, like so basically with the euphemism and trying to be more and more politically accurate and culturally accurate, they're adding more and more things, making the names longer. Initially it was shell shock, post-traumatic stress disorder was shell shock, then they called it something else, and then post-traumatic stress disorder. In future, they're going to be in longer. Eventually, the names are going to be very, very long. Just like, short chain fatty acids, medium chain fatty acids, long chain fatty acids, very long chain fatty acids, very, very, very long chain fatty acids, extremely long chain fatty acids, and extremely, extremely long. Okay, the seasonal pattern occurring only winter. And again, criteria of major depressive disorder will be fulfilled over here. And light therapy, boy is admitted for counseling, and therapist wouldn't let him travel by bus, rather wants to drop him off at his guardian's home. Therapist's own son was lost in a car accident. Diagnosis is
Countertransference.
countertransference. Okay, and transference is when the patient has feelings for the physician. Psychiatric is seen as a parent, as an uncle, anything. Similarly, a resident, there might be a resident who thinks of a patient like her grandmother, and then up. So yeah. Patient urinates up to 20 times a day. Okay, workup is not shows nothing. So transference and countertransference. Transference is when the patient thinks of the physician in terms of his father or uncle or someone else, and countertransference is when the physician looks at his patient like a son or like a father or something. So this is
The way I remember this is healthcare worker usually is behind the counter. So remember, countertransference is from the healthcare workers or the physician.
Yes, correct. Countertransfers from the healthcare worker to the patients, and transfer from sometimes patient, people end up, mixing these up. Like if the physician is thinking something about the, so sometimes what people do is they think of transference, basically think of a relationship between a physician and the patient, in which the patient is thinking of physician as a father, and father is thinking of patient as a son, and the patient is doing transference and the physician is doing counter transference. And if you remove, basically they end up basically making it something sequential, that the patient is going to do something to the patient, to the going to think of the physician in a certain role, and the physician subsequently thinks of the patient in a subsequent in another role, and basically they think of it happening at the same time. Okay, and what happens is, if they see a scenario in which the only physician's role is given, and a physician is thinking of patient as something, they end up making it just transference. Okay, because they were initially thinking that counter transference comes after transference, right? So transfers, first there is transfers and then there is counter transference. Okay, that's not correct. Simply, patient might not have any certain typical feelings about the physician. The physician might have certain feelings about the patient, and that will be counter transference. That's it. All right, don't make that mistake. I hope nobody does that. Okay, patient urinates up to 20 times a day. Follow-up shows nothing, workup shows nothing. Now stays in the library all day to learn about the cause of his symptoms. Diagnosis is so. Is this illness anxiety disorder? No, because the symptoms are significant. So this is somatic symptom disorder. If there were no symptoms and he thought if he had thought he has renal carcinoma and there are no symptoms at all, and that's what he's reading all day about, then it would be illness anxiety disorder, right? So no symptoms but worry, that is illness anxiety. But symptoms and worried about something, that is somatic symptom. This is somatic symptom disorder. What do you give treatment for bulimia nervosa? This patient has bulimia nervosa, thyroid gland swelling, eroded enamel. What do you give him them? SSRIs. Okay, patient hates her husband for being timid. Okay, timid and being coward. And tells her therapist to have courage and tell her everything because she doesn't have any respect for coward people. This patient is displaying what? So this is transference. She is thinking of, she's having the feelings of her, about her therapist of her husband. Okay, all right. So the
So
therapist.
this is not a displacement?
Displacement is when you you transfer your feelings of anger on a less threatening object and person, and usually it's done in a hierarchical situation. Okay, in which someone receives, so this so this would have been displacement, let's say, if the patient, let's say, so the question actually might include the patient has been repeatedly telling her husband to be brave. Okay, and
Okay.
yeah, and then does that to our therapist. In displacement, again, as we talked about earlier, the patient receives criticism, goes on, criticizes someone at someone else. So that's a typical scenario of displacement.
Okay.
Less threatening object, less threatening person, and receives that from the someone in higher in the hierarchy. Patient has hair loss and major depressive disorder, and no scarring of head skin. You see hair of multiple lengths. No itching. What's the diagnosis?
Trichotillomania.
Trichotillomania, correct. So significant distress, and they are pulling their hair out, and therefore the hair might be of different lengths. There's no scarring. Scarring may be there in, for example, tinea, right? So if there is tinea capitis, there will be scarring, patch of hair loss, and maybe itching, pain, etc. In patients with alopecia, there is no pain, no itching. It's a patch of hair loss with no hair at all. Okay, as composed to in trichotillomania, where the hair of different lengths, and different hair may break off from different points. Some may break off just from the root. Some may. So psychotherapy for these patients. There is something else. Some people, they eat their hair, eat hair, and that ends up blocking their GIT and forms a bezoar, right? Bezoar of hair that has to be removed. Okay, there's a chimpanzee. He solves the puzzle, and a song plays, and he receives tangerine to eat. Okay. Later on, you play the song, and you see elevated neurotransmission in the ventral tegmental area and substantia nigra. What kind of conditioning is this?
Classical conditioning.
So classical, the way you differentiate from classical and operant is, classical has to do with involuntary responsive. Let's say a baby comes to the clinic for a second dose of vaccination, looks at the nurse, and develops palpitations. This is classical condition as well, right? Because palpitations are involuntary response, right? An operant condition has to do with voluntary responses, in which the behavior increases or decreases depending on you adding a stimulus or removing a stimulus, an extension where the stimulus is gone, where the behavior is gone, completely gone. Extension can occur in both operant and classical. You stop feeding the chimpanzee with tangerine and just play the pop song all day, all night for the next few days, and you won't see any tegmental neurotransmission. Instead, now you might see the neurotransmission in the anger area. He will be very angry for that random pop song you're playing all the time. So in operant conditioning, it has to do with behavior, target behavior. So reinforcement is going to increase behavior, whether it's positive or negative, and punishment is going to decrease behavior. Okay, it can be positive punishment or negative punishment. Do you guys want me to go into detail of this positive reinforcement, positive punishment, or are you guys clear?
Yes, please.
So you'd like me to go into detail. So let's suppose there is a child and you want him to increase certain behavior. Let's say you want him to study hard for the exams, and the positive reinforcement will be you add a stimulus. Let's say you feed him with something. You tell him that you give him every time he studies for 4 hours, you give him an orange. Okay, or anything, any toy or anything, and that will be positive reinforcement. And you want him to study more, and the stimulus that you remove is, for example, let's say you tell him that if he studies hard, you won't beat him. Like, again, talking from a South Asian parent perspective, again, I am against any kind of child beating or punishment or any kind of this. But let's say, the old pervasive system of teaching back then, and the students used to be hit. So the child does not receive the beating if he studies. That is negative reinforcement. You're removing a stimulus. When you have to decrease so it's dependent on the behavior, whether you're increasing it or decreasing it. Okay, for decreasing behavior there is punishment, and you want the child to, let's say, stop watching computer all day, stop using playing video games on the computer every day. You see him using computer, you tell him he won't get any birthday present. Well, no, that would be removing a stimulus. You add some beating over there. The child watching, using computer for video games, receive some beating, that would be adding a stimulus. And if you tell the child that he won't receive anything for the birthday, that will be removing a stimulus. Okay, so you have to focus on the behavior, whether it's increasing or whether it's decreasing. Again, I don't think so it's very high yield for the exam. Again, boy develops palpitations on seeing the vaccination as a fourth visit. This is classical conditioning, because palpitations are involuntary response. Craving ice and toilet paper, pregnant woman, dry scaly lips and erythema. This is pica. There might be iron deficiency anemia, and symptoms of iron deficiency anemia and signs, for example, spoon-shaped nails, etc. Talk about that. And nutritional rehabilitation, psychotherapy, SSRIs. For 3 years, there are cycles of patient feeling sad and energetic. Okay, and none of them meets the criteria for either manic episode or hypomanic episode or for major depression. And there is no more than 2-month consecutive symptom. This is cyclothymic disorder. I've talked about this earlier. Mild depression. Okay, so sorry, not hypomanic, rather manic. No, the patient does not fulfill the criteria of manic episode. Hypomanic episode can be there. Hypomanic and mild depressive. This is what the patient is fluctuating between. If there is manic episode with mild depressive, that would be bipolar 1, right? And if there is major depressive and hypomanic, that would be bipolar 2. Depression and smoking addiction, 12 with both side effects. This is
Varenicline?
Actually bupropion,
Okay.
and that can cause side effects, can have tachycardia, insomnia, the stimulant side effects, all right? Headache, etc. No episodes at home. Whenever leaves the home or apartment, develops chest tightness, dizziness, sweaty hands, feelings of impending doom. This is
Claustrophobia.
agoraphobia.
Yeah.
All right, public places, public, all of that, and this patient will get restricted. And there is no, if the patient had symptoms at home, then it would be
Anxiety disorder.
panic disorder, because these symptoms just within, of course they have to be in the within 10 minutes, but episodes of shortness of breath, tightness. So generalized anxiety disorder, patient has excessive worry, etc., but no typical episodes of panic episodes. This is a sort of panic attack sort of episodes. Again, if these were only occurring at a certain place after seeing a cat, for example, a bat, whenever the patient sees a dog, develops all of this, and then that would be specific phobia, right? Talk about that. Patient thinks he can satisfactorily complete task as opposed to teammates. Presents with nervousness and difficulty sleeping. This is OCD or OCPD?
Personality disorder. So OCPD.
OCPD, yes. So it's egosyntonic. He thinks he is doing the right thing. Patient lost her job and now develops significant weakness. You ask her to plantar flex the ankle, she cannot do that. Reflexes are normal, no problem with CT MRI. Diagnosis is conversion disorder, correct. Reflexes are normal, and after a stressor. Student with upcoming exam decides to focus on essay writing rather than worrying about grades. This is suppression, correct. Patient has episodes in which let's say this is 25-year-old man brought by the wife, and has episodes in which he is talking to imaginary people and has childlike high-pitched voice and memory gaps, etc. This is diagnosis. So it's dissociative identity disorder. Again, these are things that you have to differentiate from one another. In deep personalization and derealization disorder, it's the patient who is telling you, that my environment, or it feels unreal, I feel out of my body and stuff like that. Okay, and they understand this this fact. This is what they are going through. Dissociative amnesia, patient cannot recall their personal information. Their patient living in Boston. In fact, there are videos on YouTube about this. A patient living in Boston found in California, and when asked by police who's she's unable to answer that. Where does she live? She's unable to answer that. The police checks her wallet and finds a card that mentions, okay, she is let's say a teacher in Boston. Okay, that would be dissociative amnesia. On the other hand, in dissociative personal identity disorder, the patient will take up a new identity. Okay, this patient, let's say another patient, the same patient, okay, wandering from Boston, wandering in California, and when police interviews her, and the patient says, okay, I work at CVS here, okay, or I work at Walmart here, when she doesn't do that. So basically is distinct identity, and she does not remember being a teacher ever. So these two are more common in females. So with sexual abuse, PTSD, depression, substance abuse, borderline personality disorder, somatic symptom disorders. So this patient will have distinct memories and pattern of behavior of the second personality. When she takes up the second personality, and she says, okay, I work here, and she's entire different pattern, does not remember anything. Dissociative amnesia, she doesn't develop another identity. It's just, the patient is found dumbfounded and completely confused, doesn't know who is she, where is she from, nothing else. It's not that she suddenly starts saying, okay, I live here, I have a home here, I am here, I work as a doctor over here. That's not what she's saying. She's saying, I don't know, she's just confused, unable to answer anything. That will be dissociative amnesia and disorder identity disorder. Patient will have a different identity. Okay. Dilated pupils, hypertension, diaphoresis, agitation, tachycardia. What's the diagnosis?
Inhalant? Toxication?
Not actually inhalant. This patient,
Cocaine abuse?
cocaine abuse, and what's the treatment?
Benzo?
Benzo, correct. Inhalant, usually they'll probably mention a rash. There is usually 5 to 10 minute episodes. Basically, this patient might be brought by the parents, 15-year-old guy. These are the folks who, of course, they are starting on testing the drugs, and of course, it's easiest to get inhalant from any shop, right? And then they sometimes they basically set fire to it. It can be in certain glues and stuff, and then they inhale it, and they develop minutes, for a few minutes, 5-10 minutes, when they are staggering, falling around, see drunk, stuff like that. That's the kind of thing they have, the way they.
So again, what was the
Cocaine. This patient is taking.
cocaine?
Yes. Okay, patient has.
Some rest.
Yeah, okay, so you guys want to take a break? It's 11:30. Let's get back at 11:40. How many starts are there? Okay, 157. We hope we'll be done by 12:10 or something like that. All right, let's see you guys.
So after then, will you after this lecture? So biochem metabolism.
So I'm thinking of doing that tomorrow. Maybe.
Oh my God.
We're extending the course. Of course, this was supposed to finish tonight, but we might take a session tomorrow as well. All right.
How many hours left now? I just wanted to know from my time here, Florida. How many more hours now left to finish the class?
We have almost 1 more hours. We might go until 1 o'clock. Again, it depends. Usually they last till 5 to 6 hours, but we'll probably be, so after 10-minute break we'll get back. You are taking the trial, right?
Yes.
Yeah, sure. So let us know, how do you feel about the session, and if you wanna. So our next session will start on.
Can I talk to you at some point to discuss few things?
Sure. So yeah, WhatsApp us and we can talk about that. All right. So see you guys in next 10 minutes.
Okay.
All right. All right, everybody, let's get back to work. Okay, so this patient presents to you low BMI, okay, secondary amenorrhea, does a lot of excessive exercise, and thin soft body hair. This patient is at increased risk of so diagnosis here is so they're actually patients with anorexia nervosa. The way they are losing weight is via doing a lot of excessive exercise. You can watch YouTube videos where there are people who would run 5-6 hours every day to lose weight, and they simply cannot. So excessive exercise, secondary amenorrhea, low BMI, this patient has anorexia nervosa, and anorexia nervosa, what will happen to estrogen levels? So these patients have low GnRH, secondary to probably high cortisol levels in the blood. Okay, so of course it's the body is in a stress state. Okay, that releases a lot of cortisol into the body, and that cortisol actually inhibits GnRH secretion. So they develop amenorrhea, low FSH, low LH, low estrogen, and of course they can develop brittle bones and fractures, osteoporosis, etc. One more thing about anorexia nervosa is that it is a state of it's a kind of euthyroid 6 syndrome as well, where the TSH and T4 may be normal but low T3, because again a lot of cortisol in the blood, okay, which is essentially a corticosteroid, will inhibit conversion of T3 to T4 into T3. Similarly, you may see a question in which the patient is started on treatment for maybe inflammatory bowel disease or basically any disease with the steroids, and now they give you his labs where TSH is normal, T4 is normal, T3 has gone down. So again, that the reason here will be use of corticosteroids. And in fact, prednisone is one of the treatment for thyroid storm and thyroid, where it will inhibit the conversion of T4 to peripheral T3, T4 to T3 by inhibiting 5' dehydrogenase. Okay. So there is a woman with suicide attempt after minor fight with the boyfriend, broke up multiple times, screamed, insulted paramedic, and splitting, right? This is a borderline personality disorder, and she will probably display splitting. Distorted time perception, visual hallucinations, dilated pupils, tachycardia, paranoid dissociation. Diagnosis is LSD. Yes. So visual auditory sort of distortion, hallucinations, and mydriasis, dilated pupils as well, and paranoia, etc. That is LSD. Social anxiety disorder has difficulty initiating sleep. You're looking for a drug. Let's say this is a 25-year-old patient, all right? Wants a drug that won't cause drowsiness in the morning for sleep. You think of initiating a benzodiazepine. Which benzodiazepine will you initiate on? What are the short-acting ones? Atom, right? Atom. Alprazolam, prazolam, oxazepam, and midazolam, right? They're short-acting. Patient will take it before sleeping. Woman has sexual fantasy about female co-workers whenever sees a same-sex couple makes derogatory comments. Which ego defense is she displaying? So this is reaction formation.
Right?
This is reaction formation. Basically, she has sexual thoughts about her female co-workers, and if she sees a same-sex couple, so makes derogatory comments about them. Basically, she herself has feelings and thoughts of homosexuality, and if she sees someone who is also homosexual, she's getting angry over them or making derogatory comments. Basically, she's doing the opposite of what she's thinking, right? Or that's why it's reaction formation. Normal BMI and erosions, etc. Parotid gland swollen, bulimia, right? Treatment is SSRIs.
Sorry.
Patient returned from Afghanistan 2 years ago, veteran, and difficulty concentration, early morning awakening, psychomotor retardation, and low appetite and lost interest. Diagnosis is? Sorry?
Post-traumatic PTSD.
Not PTSD. This is major depressive disorder because he is fulfilling the criteria of major depressive disorder, right?
Yeah.
So anytime you see full major MDD criteria being fulfilled, don't go for anything else. And this patient returned 2 years ago, does not have that typical, hypervigilance and nightmares and all those things related to, PTSD. Okay. Okay, there is a patient with obsessive compulsive disorder and presents with the increased urination, dry mouth. On labs, you find hyponatremia, urine and serum osmolality both are decreased due to water restriction, and it increases. Diagnosis is osmolality.
Nephrogenic lithium.
Would nephrogenic DIA cause improvement in osmolality after water restriction?
No, I think
This is
to prevent.
psychogenic.
So this is psychogenic polydipsia. With a patient with psychiatric illnesses, they can have it, and usually it takes around 15 liters of water daily to develop this way. Also in nephrogenic diabetes insipidus or central diabetes insipidus, you will have hypernatremia and increased serum osmolality with decreased urine osmolality, right? Over here you have both serum and urine osmolality down, and they will start improving after you start them on after you do water restriction. That's it. So they have to be monitored for water intake. Right, so he probably has excessive, feels dry mouth over and over again, and then just drinking more water. Patient has nausea or tremors, excessive sweating. She's a nurse. Blood glucose is less than 50. The only medication she's taking is metformin, most likely. Can anyone develop?
Exogenous insulin.
So she cannot develop hypoglycemia second to metformin, right? Metformin cannot cause hypoglycemia. So you have to evaluate for any other medications, for sulfonylureas,
Yeah.
or
And insulin.
exogenous insulin and all of that. Okay, this is 24-year-old guy who is imprisoned multiple times, expelled from school at 13, stealing property, threatening to assault, brutality. This is diagnosis?
Antisocial.
Yes, antisocial personality disorder. If this was not there, the expulsion from school for stealing property and threatening, then it would not be antisocial personality disorder. Okay. Okay, this is a boy who hates swimming classes. No guy friends. Only has friends with in girls, and it's affecting his academic performance, and he would reports that he would rather be a girl. This is diagnosis. This patient is not okay with his assigned gender at birth and is uncomfortable with that, and the other would be a girl, and this is affecting his academic performance. This is gender dysphoria, right? Significant incongruence between experienced and the assigned gender, and they may develop distress, persistent distress. Okay.
What does it mean by gender nonconformity itself is not a mental disorder?
Back then, they used to think that this is a mental disorder, gender, not following a certain gender norms. Okay. When it
So-
leads to persistent distress, that is probably when it becomes gender dysphoria. If someone just does not follow certain, gender norms, for example, there is a girl who, or who has basically lives like a man, right? Like men, like the average men out there, uh, and dresses up like men, short hair, and basically everything like men, lives, has a lifestyle entirely like men, but does not have any distress associated with it. Okay.
So in other name, it's the patient is egocentric about this. It's not gender dysphoria,
Yes.
right?
Gender dysphoria has to be associated with persistent distress. Okay. And affecting the, so non-conformity itself is not a mental disorder. Okay. Because of course the gender roles have been developed, like they are there of because of thousands of years of the human history and all of that. So if somebody does not conform, it's not a mental disorder itself, right?
Yeah.
Okay. And transgender is different from in which the patients undergo medical interventions, etc., to match their gender identity and become, they start living as a different gender. So now they have basically taken actions. So this is just the persistent sad distress, etc. And here we have basically making important lifestyle changes. This was the topic. Got, basically patient, when taking histories, physician has to be sensitive about patients who might, so for example, if there is a patient who identifies as heterosexual, so the physician shouldn't automatically assume that the patient would never had never had a homosexual encounter, or a patient who identifies as homosexual, he probably should be screened for any instances of heterosexual sexual, yeah, so encounters, heterosexual encounters. And again, patient should be asked how would they like to be addressed. Okay. So it's just basically over the years, we physicians have to be more and more sensitive about all of these things. Severe neutropenia after starting a medication. This is for schizophrenia.
Due to clozapine.
Correct, clozapine. What if the patient had developed high blood pressure? Well, not high pressure, maybe like hyperlipidemia and hyperglycemia. This would be
Olanzapine.
olanzapine. Risperidone will be when they develop. Man comes back with gynecomastia and
Prolactin
yes,
secretion.
hyperprolactinemia. Correct.
Yeah.
Yeah. Quetiapine seems like the least, I think, side effect one. So that is probably the one you would use. Patient has erectile dysfunction and has worries, excessive worries about everything. What drug would you give him? Taking into consideration his erectile dysfunction. Which drug for anxiety would you give him? So he has, let's say, more than 6 month history of this episode. Sleep disturbances, worrying about family, finances.
Buspirone.
Yes, Buspirone. You will give them Buspirone because does not. Yeah, it does not cause sexual side effects. Again, I didn't really do all of these things in detail, like memorize them. Partial 5 partial serotonin 1A receptor agonist, and I didn't get any questions like that. I'm not, again, I probably think this is low yield stuff. Okay, the patient avoids family dinners and social events and says she's comfortable on her own. Is this avoidant personality disorder?
Schizoid.
Yes, this is schizoid because she's comfortable living like that. Flat effect is not, no friend, etc. Okay, patient has delusions.
Sorry, Bilal, what was the difference between schizoid and antisocial?
Schizoid and antisocial or avoidant?
Yeah, you were saying avoidant. Yeah, sorry.
Avoidant. So avoidant patients, they want relationship, they desire relationships, but they get anxious and they are afraid of rejection. Okay.
Okay.
And that's why
Alright.
they don't have friends, because they cannot deal with any rejection or in the social settings, and they actually want friends. Okay.
Okay, thank you.
As opposed to schizoid people who don't want friends any. They want to live alone
Can
as
you-
like.
Excuse me, can you show the previous the question? I am, yes,
This patient has generalized anxiety disorder, has restlessness, sleep disturbances, worries about everything, and also has erectile dysfunction. Okay. So usually what you use SSRIs, right, for generalized anxiety disorder. For this patient, you will use buspirone, because buspirone does not cause erectile dysfunction.
I see.
Okay, so you're trying to avoid the sexual. So you have to keep all the contraindications in mind when you're starting medication. Okay, let's talk about that.
This is the antisocial disorders. Oh, there was woman. Yes. Oh no, the previous question. Can you? Yes, the woman. The woman. No, next question. Yes. Oh no. The woman. Yes. Oh yes. Oh yes. This is antisocial disorders.
This is schizoid personality disorder.
Oh.
No friends and is comfortable on her own. Doesn't want any friends. Okay. The avoidant personality disorder patients, they want friends. Schizoid don't want any friends.
Thank you.
This is a typical, avoidant personality disorder guy, the typical South Asian guy studying in US, wants to be friends with a lot of girls, but cannot approach them because of anxiety and fear of rejection, and ends up has no friends over there, but he desires friendship. Okay, so but you will find them on the Facebook. Okay, delusions, old man delusions. I repeat same information. MRI shows atrophy of anterior thalami and small mammillary bodies. Diagnosis is
Wernicke-Korsakoff.
yes. So secondary to alcohol abuse, and make sure you see some MRIs of mammillary bodies where they're located. So mammillary bodies are located posterior to the brainstem, right? And anteriorly you have, they are located anteriorly, and posteriorly you have pineal gland, for example. There's a problem with people, they end up mixing the anterior and the posterior brainstem structures. Yeah. So the course of a cough component is irreversible. Confabulation, usually they will fill in the gaps very confidently. So this is a patient who was admitted for maybe hip fracture, and now she's agitated, unarousable during the day, but awake during the night. Inattentive. Delirium, yes. Pulling on the, this is a favorite question of the examiners. And how do you treat them?
Haloperidol?
Yes, haloperidol for immediate treatment, and of course you have to make sure they keep the lights off at night, keep the daytime lighting should be on, familiar environment, familiar people, not too much changes in the nursing staff rotating at them. So yeah, haloperidol can be used as needed in the acute setting, and avoid restraints and the drugs, benzodiazepines. The patient agitated, Someone might think, okay, let me give this patient lorazepam, opioids, or anticholinergic. Don't give them to these patients, anticholinergic drugs, because anticholinergics, again, they cause confusion and they have their effect on the brain, and no restraints. Don't, that will worsen delirium. You want to return them. You want to return, and mostly in elderly, UTIs and erectile disturbance is most common cause. Elderly male, okay, either constipation, 4 or 5 days of constipation, and then all the symptoms of delirium, or urinary retention, hasn't passed urine. There's a suprapubic mass, which is a bladder, and you know, secondly to BPH, that could be delirium, or electrolyte disturbances, hypokalemia and all of that. So you do immediately, what you do is you check for electrolytes in these patients, and for infectious markers. You may be thinking of sepsis or UTI when an elderly is brought. The problem is elderly is that they might not have the typical infection, inflammatory signs like fever, etc. They might not have developed fever with UTI. They might be in sepsis without any fever, right? Okay, patient have vivid nightmares, re-experiences the accident, works in accident, avoids driving car with non-pains and old close friends. This is typical symptoms of. She had lost her unborn child 4 months ago. So PTSD, and has to be more than 1 month. Should last more than 1 month. And all these typical symptoms. A patient with obesity says it runs in our family, and thus rather fighting, I just want to enjoy myself and eat what I want. Which ego defense is he using? So this is rationalization. He's justifying it. He's saying, this runs in our family. While the actual answer is, what do you answer? How do you answer it? Obesity runs in your family because no one runs in your family, right? That's the answer to. So this is again an immature response.
Passive aggressive.
Passive aggressive, correct. Patient, this woman is given an additional project. She doesn't want to do it. Again, she just family emergency. My department, the problem with our department over here is they also keep giving us way too much of work, relying on us way too much, not increasing our salaries. For the past 4 years, they haven't raised any salaries, in fact, stopped. And some people, what they do, so I haven't done that, but one or two, they want to avoid work. They said, I had COVID exposure, I cannot come to the hospital. The other day, I told them my wife is in labor. Well, I didn't tell them because I am unmarried, so that cannot happen. Okay. So CKD patient has talkativeness, low need for sleep, jogging all day, motor agitation, pressure, speech. Diagnosis is by probably a manic episode and bipolar disorder. How would you treat this patient? What drug would you give him?
Well,
so not lithium, all right? CKD patient. So you give him valproate. What if he also had chronic liver disease? And then you will think about the other medications, correct? Like valproate.
Yeah, carbamazepine.
Or we will talk to him about advanced directives. Anyway, that's very bad. Young man brought up ministry falling is feeling agitated, feel ants crawling on the skin, tachycardia, high BP, skin warm touch. Diagnosis is crawlies and tachycardia and blood pressure and warmth. Cocaine. And what test you order?
Urine toxicity.
ECG.
Urine drugs test. You give the patient benzodiazepine, etc.
So Piru's the question was no sleep. Yes, this one is.
This patient has a manic episode, and you give this patient. You don't give him lithium because he has chronic kidney disease. Lithium is exclusively,
Oh.
yeah, so he can develop lithium toxicity. Therefore, you will give him valproate instead, all right?
Valproate, right.
Those of you who have watched the movie, you know, the Pakistani Indian folks who have watched the movie Dhamal, anyone of you, right? Where the plane scene in which basically the guy from the control tower, he starts telling these two folks who are flying the plane to start praying to God about for the forgiveness of their sins when he realizes that the plane cannot be salvaged. All right, do you guys remember that? अब हम क्या करें? अब आप मिलकर मेरे साथ साथ दोहराइए. ऐ भगवान हमसे जो भी पाप. Anyway, that's something that if you have a patient who has you know, all the diagnosis and treatment has failed, and now he says, okay, what should he do? Okay, very bad of you. This is kind of dark comedy. Anyway, so rash between upper lip and nostrils, seemingly drunk, you know, falling, staggering around, slurred speech, mood swings. Episodes short, last, you know, 10 to 15 minutes. Red eyes, and this is inhalant abuse.
Inhale, okay.
This is inhalant abuse. Short episodes of basically slurring and staggering, red eyes. Okay. Inhalants over here. So slurred speech, disinhibition, disturbed gait, you know, parents think he's sort of, you know, appears drunk, the drunk guy falling at left, right, center, and drowsiness, rapid onset resolution. Patient was fine, then developed symptoms. After a few minutes, it's fine again. Okay, so this is short episode, 10 to 15 minutes, and maybe rash.
So what are the inhalants that can be abused? Like, is it like ether or something?
I heard the, you know, glues.
Glue sniffing.
Yeah, like Samad Bond, and
yeah.
I think I heard those
exactly
can be used as an inhalant. Opioids withdrawal, again important. Piloerection is the thing that you will help you. Piloerection, flu-like symptoms like rhinorrhea, yawning and piloerection pretty much give clue to the for the exam or in the exam day. Keep an eye for that, and you treat them by withdrawal. You actually give them opioids, methadone, and buprenorphine is again. Buprenorphine mode of action is it's partial agonist, right?
Yeah.
Okay, barbiturates, they are known for respiratory depression and cardiovascular collapse. Benzodiazepines are not known for that. So patient with benzodiazepines overdose, you know, the treatment might be just you know, supportive. And again, as I mentioned earlier, flumezine is rarely used as it can precipitate seizures. All you need to do is, you know, just wait for the effects to go away. But barbiturates, they can be in fact used for suicide attempts and stuff, and they can actually lead to complete suicide, delirium and collapse, severe collapse, and respiratory depression. Alcohol has AST more than ALT, but again, these markers will never go beyond 1000. Okay, usually AST 400 ALT, 200 AST, 300 ALT, 150. This is the kind of levels they will be in. Okay. And what else you'll find in alcohol in the lab findings? You'll also see you'll find macrocytosis. So keep an eye for that. MCV 105. Okay. And GGT will be raised. GGT is a marker of alcohol use. GGT is found within the mitochondria, and alcohol is also a mitochondrial toxin. And treatment is longer acting benzodiazepines. Unless patient has liver disease, then you give short acting benzodiazepines. Okay, patient has suicide attempt, family history of suicide. Okay, there are multiple risk factors of suicide in this patient, what's the biggest risk factor for suicide or future attempt?
Attempted suicide.
Recurrent.
Previous
You-
attempt is the biggest,
yes.
highest risk factor, right? Out of all of these. So no spouse, single folks, okay, chronic illnesses, especially, Huntington disease, for example. A lot of people with Huntington disease, they commit suicide. Psychosis, ethanol, because ethanol will lead to disinhibition. Patient thinks of suicide, takes ethanol, and previously was hesitant in using the firearm. Now with ethanol, that he is disinhibited and can use the firearm. Again, depression and hopelessness. In depression, the most sensitive thing for think about suicide is hopelessness. If the patient does not see any hope in future, and previous attempt is the highest risk factor. Young adult and elderly, they are more likely to, especially if they're men, they're more likely to complete suicide. They will usually use the lethal means. Usually the folks with in the 40s, etc., 50s, they might actually have they will probably be married, they will have children and stuff, so they will probably not complete. So as opposed to a 20-year-old unmarried guy or an elderly, increased risk of actually completing suicide, right? Males, because they will use more lethal means. Females will usually use drug overdose, which can be managed and treated, and males will usually use lethal means, for example, firearms. So protective factors, medical, so effective care, community connectedness, especially in South Asian and in Asian cultures. Long, strong cultural, religious beliefs encouraging self-preservation. So in, for example, Catholics, Christians, or in Muslims, where it is not permissible basically to harm yourself. So less, and strong problem solving skills. You face a problem, you solve it, you're good, as opposed to becoming hopeless and then okay. So women try more often, men complete more often. Talked about that earlier. And if you see a patient who has suicidal ideation, what you need to do? Admit them, right? And if organized plan and suicidal ideation and organized plan, and if the patient has firearms at home, that they have to be removed, right? Firearms can lead to complete suicide. Women got in fight, irritable, combative, visual hallucinations, rigid muscles. This is
PCP.
PCP mode of action is and NMDA antagonist. They haven't mentioned it, but what else is NMDA antagonist? An anesthetic. Ketamine.
Memantine.
Yes, memantine, ketamine. Yes. In fact, ketamine, one of the side effects of ketamine is actually sort of hallucinations and a state of altered sensorium. Conjunctival injection, paranoia, dry mucous membrane in college guy from party, tachycardia. This is cannabis, marijuana, and will also have impaired reaction time, perception of slow time, impaired judgment, social withdrawal, increased appetite, dry mouth, all of this. Okay, patient for the past 6 years, the patient women believes that someone is watching her through security cameras, and whenever she is moving in the city, she hides her face. Okay, however, she's doing otherwise well, recently promoted, and rest of this is unremarkable.
Delusion.
This is delusional disorder. More than 1 month of history, and there are no hallucinations. There are no, psychomotor retardation, agitation, or disorganized speech, and all of that. So just a fixed belief. That's all, which cannot be reasoned with. You cannot reason and convince them out otherwise. Depression patient started fluoxetine, later has delayed ejaculation and anorgasmia. First, was you switching to?
Bupropion.
Correct. Patient dressed very extravagantly, flirts with everyone. When not receiving the attention, cries, flirts with the physician, it makes unappropriate comments. This is diagnosis is histrionic personality disorder. Histrionic personality disorder. Okay. Patient this leg cramping, runny nose, chills, yawning, diarrhea, cool damp skin, piloerection, direct pupils, withdrawal from
Opioid.
Yeah.
Opium.
opioid withdrawal. Correct. Man thinks he's too thin and lacks muscle and hair are thinning, and therefore applies minoxidil thrice a day. When you examine him, you find him normal, appearing normal. Okay. Diagnosis is
Body morphism.
body dysmorphic disorder, and if he was, let's say, doing, if he was having those dietary patterns, then you could think about maybe bulimia, etc. So body dysmorphic disorder, preoccupation with a minor or emergent defect, and this could be, for example, in patients with mild acne. There is a patient who has maybe 1 or 2 comedones on the forehead and comes to you and says, like, I look horrible, terrible, my entire face is full of acne. And so significant distress and mirror checking, excessive grooming and if associated with eating patterns changes, that could be then you would diagnose the patient with bulimia, neurosis, whatever. So you do CBT again. CBT. Okay. Patient has unable to sleep. Physician tells him, sleep when leave the bed if you are unable to sleep, and come back once you are really sleepy, and use the bed for sleep and sex alone. What intervention did the physician make?
Behavioral counseling.
This is called stimulus control therapy, in which you are establishing the bed as a strong clue for sleep. And what is sleep hygiene? In which you, for example, stop taking caffeine after 6 p.m. in the evening. No strenuous exercise right before sleeping. Not taking too long naps in the afternoon. Someone who's sleeping 3 hours in the afternoon might have difficulties sleeping in the night. Again, using phone and screens in the bed. All right, watching shows in the bed. These are the other things that basically can cause insomnia. Okay. Bradycardia and a low respiratory rate, constricted pupils. Diagnosis is?
Opioid poisoning.
And treatment is?
Naloxone.
Correct. Naltrexone. What can it be used for? So this is naloxone, correct? I'm talking about naltrexone. So naltrexone, its other should also include for alcohol and nicotine cessation. It reduces the alcohol cravings. Okay, it reduces the nicotine cravings. So this is a patient with alcohol addiction, and he wants something to reduce cravings. You can't give him disulfiram, right? Because disulfiram works with after the patient has taken alcohol. It won't affect the cravings, right? So naltrexone is probably more effective than those disulfiram like kind of things.
So naltrexone is more effective?
Yes, in alcohol and nicotine cessation, it's a long-acting oral opioid. In emergency situation, you use naloxone. In emergency,
naltrexone can give the both of cessation? For
the alcohol and nicotine cessation. So naltrexone, so somehow alcohol and nicotines their cravings are associated with basically these receptors in the brain, opioid or dopamine receptors, I think, and that's where I think naltrexone goes in and works and reduces alcohol, nicotine cravings. Okay. So yeah, this is in the emergency setting, and in fact, patient with opioid overdose brought to the hospital, you give naloxone, within minutes the patient will be up and fine, and then after 15 minutes he might go back into respiratory depression and all of that. So you might have to give the this continuously, like an IV infusion and stuff, if the patient is on a long acting opioid. Again, make sure you keep the difference in mind when it comes to, for example, a lot of people, they end up mixing naloxone with the methadone. For example, methadone is an opioid agonist. Buprenorphine is a partial agonist. Naloxone and naltrexone are antagonists. People end up mixing all of these, okay, or their mode of actions. Methadone is given, for example, if a baby is born and the mother was using, was doing heroin abuse, and has all the baby has all the findings of basically alcohol of opioid withdrawal. So you can use methadone for them, or a patient with opioid withdrawal in detoxification, long term, not acute overdose, but long term detoxification for heroin. So methadone, you can basically start them on methadone and then slowly reduce the methadone, because the problem with a lot of addictions is that people cannot deal with the withdrawal effects. That's where they want to take the drug. They become used to it. They might hate it but they cannot deal with the withdrawal effects, and they're going to take it. And that's what you're helping with them with. So methadone, you start them on methadone and then slowly reduce until you stop methadone after a longer period of time. Buprenorphine, because of being a partial agonist, if a patient comes to the hospital and undergoes hip surgery, and for pain you start him on buprenorphine, develops all the withdrawal symptoms, maybe he was previously opioid addict, right? He might have addiction of opioids earlier on, or addiction of so what's the most common form of opioid addiction in the US, for example? Is it heroin? So it is actually the prescription opioids.
Yeah.
People get addicted to those, and that's the most, and in fact those are the most common cause of death as well. The prescription ones, people use them, overdose on them, or end up. Okay, pretty much we have done this. It's 12:24. I think let's do the metabolism thing tomorrow. Okay. And
Bilal,
we'll also do the
was-
the pharma as well, basic pharma and metabolism tomorrow. Okay.
Bilal, I have a question.
Now it's
There was an SSRI question that you put on in the slides regarding sexual dysfunction, and you said that what other medication can we give? What was the answer?
Bupropion.
I think it was okay. Bupropion, right?
Bupropion does not have sexual side effects, so these patients may be switched to bupropion. Right? Any other questions?
Can you post these questions in the group?
Yeah. I'm gonna put the slides on the groups. All right.
Yeah. Thank you.
After we will do pharma basic now.
No, basic pharma and metabolism tomorrow. All right.
Tomorrow, so we will take some rest now.
You take the rest for the next 24 hours, not 24, 18 hours. We will do basic pharma as well as metabolism tomorrow. Okay. We'll start with metabolism, and we'll then finish all those graphs and stuff. And I think we also have to do the.
But I have tomorrow. I have work. Oh my god.
Okay, so then you can access the video. I'll send you the link to the video. All right.
Okay. Next time. Okay.
Yeah, you can take the same session in the next upcoming batch. Okay, when you were doing the metabolism and
3 hours. Okay.
Yeah, sure. You can take the session again. Anyone can take this. All right, everybody.
I have a question, but when you're done with our last year.
So Srija, sorry. So actually, your voice have been a little throughout the actual course a little of low volume and maybe some little background noise. So sorry, can you come again, or can you about?
Yeah, I can talk to you if you have time.
Yeah, sure, sure.
Yeah. So yeah, I will join it, and I don't know whatever you want me to do. I will join. I will fill the form. So, couple questions. I work here and there. So when I'm working, do you send me link or something so I can catch up that classes?
Srija, I'm having difficulty in listening. Are you guys having everybody else having the problem that problem as well? Like your voice is
Yeah, the volume is little low.
Yeah, the volume is low, and yeah, it's somehow there's some background noise. It's not very clear. How about you get back to me on the WhatsApp? All right, Srija.
What time? What time?
Okay, so I think I can put my number over here, my WhatsApp number. Oh, rather, my phone is going to be taken away from me tomorrow, but I will figure out a quick way to do something.
Can you hear me now?
Yeah,
Can you hear now?
Yeah. So.
Okay. So you can hear now? Can I talk now?
Yeah, sure.
Okay. No, I was saying that because I work a couple days, so when I'm working, do you send me a link or something so I can watch your lecture? Did you hear me?
No, I'm still having trouble.
She was saying that she would like to join, but the thing is she's working like few days in a week, so she's wondering if she's gonna get the link for the sessions that she's gonna miss.
Yeah, sure. So we share the recordings as well as we share the all the materials and everything on the groups we have. So yeah, so you can text our coordinator. Muntazir has been in touch with most of you guys. This time he's a student over here as well, third year medical student. We thought he may deal with all the clerical work while we focus on our work. So I think he has been in touch with a lot of you guys. So you guys, Suji, you can get in touch with him, okay, or fill in the form for him. Yeah, and there's a link of the WhatsApp in the form. That's what Motazir is using, and he can, I think, coordinate that with you.
Okay.
Yeah, so we will try to facilitate, and in future we might actually do courses that might be cater to the people in the US in a way that they will be evening time in US. So for Pakistan, they may be like 4 a.m. in the morning, 4 a.m. to 8 or 9 a.m. here in the morning, and they will be more kind of 7 or 8 p.m. in the US till 12 p.m. But again, that again depends on the number of participants in upcoming courses, and that depends on if we have majority of our participants from the US, Canada, and the Caribbean. From that timelines, then because the problem again, we people here in South Asia to getting up, I can get up at 4 a.m. but because I have to teach, but people to take a session at 4 a.m. would be difficult for people over here. So that's why.
Okay. Also, one more thing. I'm planning to take exam by end of this year. So
okay.
Even I can get a study plan or something like how to study the thing.
So you have a lot of time. So if you're planning for end of year, you have around 9 to 10.
September. Planning September.
Okay, September, around 5-6 months. I would recommend. Have you started Uworld? If you have started Uworld, so
got the Uworld started a little bit, but not too much.
So yeah, so I would recommend doing Anki if you're not doing it. And since you have 6 months, I think you can finish a big Anki deck. For example, light your Anking. Okay, 22,000 cards or 30,000 cards from Anki, because this will help you consolidate information as you go on and on. I'd also recommend doing practicing questions other than Uworld in the evening time, maybe just for the sake of practice. Practicing questions from MBOS, and then maybe some RX question. But RX is pretty much recall based and not too tough questions. And
so you are suggesting MBOS questions?
Yeah, emboss questions just for practice cell. Not, you don't have to review them properly, just for the practice in the evening. So what I would, the schedule that I advise people is, do a block of Uworld in the morning, then review that block in 4 to 5 hours. By lunch, you're done. After lunch, you do Anki, and you do, again, of course, you're working, so you will have to figure things around
Can
that.
you, excuse me, can you little bit slowly, I want to listen to, can you little slowly?
Okay, all right.
Advice.
Sure, Star. I was talking about the schedule that I have usually recommended to people, that start with a block of Uworld in the morning. Okay, then finish reviewing that block by the lunchtime, and then in the afternoon and evening, do Anki, maybe some stuff from FA. Maybe you can practice a block or so from any other question bank, but that should be the priority list. Okay, Uworld, Anki, and then FA and other things. If you have time, well and good, you can do practice more questions, you can do these passive things, but keep Uworld and Anki on the top of your preparation. 90% of your time probably should go to these two materials.
Okay.
Bilal, I have a question. How did you manage to open your Anki deck on iPad? Yesterday you were saying. I actually tried to download the app as well, but the Anki deck that you shared was not opening somehow.
So you cannot directly. So you cannot open your decks right from your iPad. That's what I understand. You have to upload your deck from your laptop onto your Anki account, your email, and then you have to synchronize your iPad Anki app, and your app on iPad will basically download from the Anki. So Anki, you will upload to the site from your laptop and then download into your iPad. That's my understanding.
Oh my God, it's too tedious.
I know. Of course, it's a one-time effort, and initially I did the same thing. I did and the thing is, once you upload your text, all the text to your Anki website, the cloud storage. Now you can download them onto your so you can use any phone, any iPad, any iPhone, and since they are there in the cloud, okay, you can simply sync from any device, and you will have all of your decks suddenly. Not suddenly, of course.
Bilal, I don't have MacBook. I don't use MacBook. I have an HP laptop.
So HP laptop has Anki app. Go to Anki website. Anki app for Windows, for MacBook is there, for Android is there. These three are free versions. The iPhone one costs for $25. So
all right, thank you. I will try to figure it out if I can do it. Otherwise, I might need help.
So we might actually spend like 20 minutes, maybe in the next batch, talking about Anki. How to upload your materials.
Please.
Yeah, we can do that.
Because I still cannot download the Anki problem.
Thank you.
Yeah. Okay. So we'll do that in the next batch. We'll try to actually do a 20 or 30-minute dedicated section on how to use Anki effectively. Okay, and how to manage stuff.
I have two questions I wanted to ask. First of all, I'm starting to study for USMLE for the first time. I just finished third year. I started fourth year with my clinical rotations. So am I supposed to finish first aid first and then start revising first aid with Uworld? Or should I do it spontaneously, both together parallel?
You can actually do this spontaneously both, especially if you're doing Anki. It depends on your baseline knowledge as well. So where did you graduate from? Sorry, where did you do which medical college are you studying at?
I'm studying in FUMC Islamabad.
Okay. So you guys do pathology in fourth year, right?
No, like my batch, we were the last ones. We finished patho and pharma in third year.
Okay, so you're done with pathology. No, so you are a third year medical student, right? Or you are fourth year medical student?
I'm done with third year. Like I just finished. So I just gave my.
So you have pretty good, I believe you have pretty good baseline knowledge. You can do them spontaneously, I would say. Again, what I would recommend is start Anki and But something else, okay, it also depends on your timeline. When you're planning to, you're also planning to take your exam by the end of this year. Basically, you want to take the exam while the score is around, right?
Yeah, so I was honestly thinking I give it during October because end of December I have fourth year finals in Pakistan. But what I'm also getting confused is I'm having 2.0. Some people are telling me to give it in 2022 since the grading is changing into pass and fail. And
so even
step two is going to be has more weightage.
No, so the point is, even after they start, even in future 2022,
So, look,
2023,
I just need to find out.
Your scores will continue to be reported. Even after it's pass fail, those who took the exam while it was score based, your scores will be reported. And they will, if you score well on step one, for example, anything above 240 plus, for example, especially for an IMG, of course, non-Caribbean IMGs, because of course for Caribbeans it's relatively different because the system. But like South Asian IMG, if you can manage to score to 40 plus, to 50 plus, something like that on your step one, that will play an additional good role, especially in a crowd of people with most of them having step one just pass. So yeah, CK will matter, but let me tell you, CK is 70% based on step one. 60 to 70% of your knowledge. I haven't been reviewing my Uworld blocks. I'm basically pretty much using my clinical engineers knowledge and my step one knowledge and FA knowledge to take. I've done around almost 60 to 3 blocks in the past 3 weeks of Uworld. CK is Uworld, and my average is 82% right now, and it's primarily coming from the step one. So study well for step one. If you can take the exam, of course, and this will be dedicated. This will be direct. You can start your preparation, keep working hard, and then believe and trust your NBMEs and your scores and your predictors. If they're good, well and good, you can take the exam this year, right? And
yeah. Initially, my plan was to give it here because I was getting mixed research and stuff. They're saying it's better for expats with like non-US graduates to give it now because like they're gonna look at your CV and all of that.
Correct. Completely true. Step one score.
Know about pass fail. It was gonna be like PLAB, like they don't check your score. I did not know that.
So pass fail, again, there is essentially it's going to remove a layer of filtering, right? Now you have only pass or fail, as opposed to having scores for CK. So of course CK will be one thing, but
it's better to give it this.
Yes. If you can do that, go ahead. Yeah, give it a shot. Study properly. Do Uworld, do everything, and if it works out, well and good. In any case, I think it's a great idea you're in fourth year, and if you have time and everything, if you can spare 4 to 6 hours a day, consistent prep, and of course more time on weekends. Of course, you have class and everything. So within next 6 to 7 months, Uworld, a block a day takes 3 to 4 months, right? And it takes 4 hours to review a block, 4 to 5 hours. You do a block in an hour. So in 5 hours, one is done with a block as well. So a consistent 5 to 6 hours study every day for 4 to 5 months is a guarantee to finishing your Uworld. All right. And if you finish your Uworld, it's basically 1.5 month in which you finish incorrect, you do UWSA, you do some NVMEs, and you're ready for the exam. All right. So that's so simple. The problem with people is they end up pushing Uworld back. And so in your case, if try going through FA, and in fact, you're actually starting like on Monday, right, with the new batch, right, Maru?
Yeah.
So in fact, what you can do is actually spend these 2 weeks with us, and then I think you're ready, well and good to start your Uworld. Okay.
Okay.
Yeah, I think you can take 2 weeks. It's totally fine. 2 weeks, not one. So after 2 weeks, you can start your Uworld. You would well
so
and good.
In 2 weeks, you cover state.
Yeah, you will be done with most of the FA with a lot of questions. We try to cover the most the high yield test material in every session. 4 to 6 hours every day. So just like that, we had we covered a lot of psych today. Most of the questions and then the concepts you will get on the exam or in the upcoming question banks. So I think you will be good after 2 weeks if you are really active in the sessions, and you will be fine. Yeah, you're good after 2 weeks to start Uworld.
So you're saying after 2 weeks of this year class, you just need a Uworld first aid, that's all. Do I need to watch, because I was watching Above and Beyond, some of those videos constantly. So what do you think?
You mentioned, you said Board and Beyond, right? Board and
Well,
Beyond.
yeah.
So I used Board and Beyond videos. So I watched some of them. In fact, I made a list of videos that were on the topics, which you forget frequently, and I watched them. Uh, Something interesting about Board and Beyond is actually they have been developed through FA and Uworld. This is my understanding of Board and Beyond. After seeing the videos and stuff, like Dr. Ryan, what he has done is basically he has taken FA and Uworld and somehow,
Yeah.
gotten the concepts together. So definitely Born and Beyond is more than FA, right? Uworld goes on, covers like 30-40% of material that's not in FA, all right? And that's what Born and Beyond is doing, helping you do as well. It covers more material. It's basically, he has made slides that include points from FA as well as Uworld, and people who are doing Born and Beyonds, when they do Uworld, they're doing better on Uworld after doing Born and Beyonds, because the concepts that Uworld is testing have been mentioned in the Born and Beyonds, right? So yeah, it's a good resource, and with a comprehensive more than FA. Same for me when I was doing Zenki deck, and the other deck, Lightyear. Both of them, they cover more than FA. All right. So I was basically, so they both cover FA plus Uworld in a way. Okay, and also Python and everything. So throughout the year, I was basically, from the very beginning, I was doing and reviewing stuff which is basically the entire syllabus of FA, of step one. So if you take step one entire syllabus, the content the entire content that touched on the exam, FA will cover maybe around 60 to 70% of that, and then 30-40% from the Uworld. Okay, and that's why you have to basically, these resources, they Anki especially,
How many
they help up.
you told, excuse me, you told too fast. So how many percent is Uworld and then first aid?
So first aid, I think of the total content, of the concepts, I think FA covers around 60%. Okay, and then for 30-40% additionally is covered by Uworld. Of course, Uworld covers most of the stuff in the FA as well. All right. So Uworld is more comprehensive than FA overall, and right now they have around 3,300 questions. So Board and Beyond is good because it includes concepts from Uworld as well.
So if I'm starting right now, I was thinking if I do first aid and Boards and Beyond simultaneously, and once I'm done with both, then I start with Uworld?
That's fine. If you can get it done within a month. I wouldn't, unnecessarily postpone starting Uworld more than 1 month from now. Within a month, 2 weeks with us in the sessions, and then maybe a week or more on some, Board and Beyond, some videos and stuff. The problem with people is they end up spending way too much time in the pre-Uworld phase. That that's the so it's the good. It's important to actually start doing US assembly style questions early and early. Okay, that's actually a good indicator of your step one score.
How many questions if I'm taking exam in September?
So I think a block a day of Uworld. So Surija, a block a day of Uworld, and I would probably be someone who will be doing another block from any other resource in the evening as well. I will probably be doing 2 blocks a day.
So if I do one block, which is a 40 questions, so within how long I should finish one what do you call?
So you will be done with the Uworld in 3.3 to 3.5 months, because there are 3,300 questions, and you will be done in 3 months.
So I won't get time to repeat it.
Well, I didn't repeat it. You will, of course, after that you will do the incorrects. Okay. And if you have time, you can repeat it as well. When you're repeating, of course, people are doing more questions a day, right? More blocks, and a lot of blocks a day. Essentially, protracting your Uworld prep to way too long is in itself not really good for you, because you end up forgetting a lot of stuff, concepts and stuff you did earlier. Okay, so I wouldn't recommend anyone doing stretching their Uworld way too much, because they're unless of course you're doing Anki. Anki is something that helps you retain stuff over longer periods of time. For me, it was for several months. So yeah, I was. All right, everybody. See you guys tomorrow at 8. We just realized Reddit also is a great resource. I haven't used Reddit in terms of forum. but we just realized today that Reddit is a good forum to actually post our course, and let's see if we get some success over there. So thank you guys. See you guys tomorrow. All right. Shahira, Anki Web decks downloading from the Anki Web. Yeah, correct. Anki Web website. If you have uploaded them over there, you can download them from there. And Anki Web website also has a lot of decks, other that have been uploaded by other people.
So, Dr. Bilal, I'm always confused in delusional disorders and mania, schizophrenia. How it can differentiate delusional disorders?
Schizoaffective and schizophrenia, right? Schizoaffective disorder and schizophrenia. So schizoaffective disorder will have mood symptoms, either bipolar or major depressive disorder symptoms, along with a period of psychiatric of psychosis, psychotic symptoms without mood symptoms. So let's say you have 2 weeks of psychotic symptoms, and the next month you have 2 weeks of major depressive episode, 2 weeks. Okay, this would be schizoaffective, for example.
So delusional disorders. Delusional is small symptom or
delusional disorder. Delusional only has delusions, but no disorganized thought or no hallucinations or no the other criteria of schizophrenia, in which the low mood is there and stuff. It's just typically one specific delusion that the patient has.
Okay, thank you.
Thank you.
All right, everybody.
Much.
All right, see you guys. See you guys on. See you guys
tomorrow. If you teach the Anki, I would like to.
Probably not tomorrow. Probably with the next batch. We will make sure.
Okay, thank you.
Yeah, we'll let you guys know. We'll let you guys know on the groups. Of course, we'll continue to share links.
Okay, maybe after this. Okay, thank you.
I won't be able to attend tomorrow. Mine is Monday because I'm the new batch, right?
All right, sure, Seja. Whatever works for you. Okay.
Thank you.
You can, Seja, you can get in touch with the, either Saad or the other Muntazir, and they will help you get into the groups, because currently I have not been really. Of course, I've been replying to the individual texts, etc. But I'm trying to. So next, in the upcoming batches, I'm trying to even push more questions into the sessions. Of course, we're doing around more than 100 questions every 100 questions. And then, of course, a lot of concepts that are just verbally discussed. But I'm thinking of making it even more question oriented, because that's what matters on the end of the day. In upcoming batches, I will probably be adding way more questions, and maybe by the end of there might be a point where we are actually doing maybe 4,000 or 5,000 questions in the entire course.
Okay.
All right.
Thank you.
All right, everybody. See you guys tomorrow. All right, everyone.